Health and Government Operations Committee. Thank you for your patience, for allowing us some grace to be late today, and it's probably going to happen. We have 35 days left because we are voting, we're in hearings, we're on the floor, we're in meetings. So we need to be flexible, and as I like to say in this committee, Gumby. All right, so thank you so much. And it's raining out there anyway, so better here where you're dry. I'm gonna go through some very quick rules. Where you're sitting in the gallery, there's no food allowed or drinking because our staff cannot, they don't have the time to clean up. You'll see that we drink here, but that's because we're here for hours and we need to stay hydrated. Please set your devices to, I'm gonna do it myself, to vibrate so you're not embarrassed. Especially if you have some funky music, right? In this committee, I have decided not to time the sponsor of a bill when they give their testimony, but please don't take advantage of it. That doesn't mean 15 minutes, 10 minutes. That means 5 minutes, okay? And then everyone else gets 2 minutes. And there's a timer that is displayed on the screen. When it goes off, please wrap your thought. I don't want to interrupt you, but do it yourself as well. Please adhere to the committee. And I want to thank you again for your hard work, a lot of work. Thank you for being here and doing it and for being on time. Remember to ask your best question. We don't need to ask a lot of questions if the bill is clear, if the bill has a huge fiscal note, right? Because we cannot get many bills that have huge fiscal note this session. But in addition to that, we do have subcommittee, and this committee does 99% of it works on subcommittee as well, which means that we invite everyone again and we dissect it and study it as well. Members of the public are able to view us on live stream right now as I'm speaking and on the YouTube channel. The bill orders are as follow, but please keep in mind that I may have to change it because if you don't see a delegate, it's because they have hearings in other committees. And sometimes there may be a witness that is coming but is running late because of traffic, and I try to be accommodating. If there's a panel that we have a lot of favorable and a couple unfavorable, I'll do a favorable, but then to be fair and balanced, I'll stop and take an unfavorable panel so that we can be balanced as well. And we do have also some virtual witnesses. For now, at 4:04, this is the order, but I reserve the right to change it. We do have... I want to go first with the disability bills because I know some of you need to go home and it's not difficult to get here. So I believe that's 1142. You did. How about 1244? Let's start with 1244, which is Delegate Guyton. Is she here? Can you please call her office and tell her to come down? So we'll do 1244, we'll do 1244, 1053, we'll do 1142, 1109, 1066, 1136, 1083, 1146, 1289, 1131, and 95. But I may change it. Is there a panel for House Bill 1244 here? Anyone that was going to testify that is here on that bill? That's Delegate Guyton's bill. Can you do me a favor? I'm going to call the following people. Alicia Wopak, Rachel London, Laura Howell, Andy Culp. Can you come up while we wait for the delegate? Go ahead. I am calling right on time. I'm calling your panel. Ken say you don't get the red carpet treatment here in HGO. So again, Alicia Wopak, Rachel London, Laura Howell, and Andy Culp, will you come up with the delegate, please?
Sorry, I'll try to catch my
breath. That's okay. Take a second. Take a minute.
Thank you, Madam Chair.
And all of you, will you be so kind while she gets ready, make sure that you put the microphone closer to you so we can hear you? Yes.
Madam Chair, I have the wrong bill. Excuse me.
Oh, yes. If we're asking questions in the committee, just ask the question. We don't need a story or anything like that, just the question, okay? Thank you. Thank you very much. Go
All
ahead.
right, thank you again, Madam Chair. And my dear friends
Thank you.
on HGO, I apologize for making you wait one moment. I was just finishing up another disability bill and appropriations, so thank you for your patience, and I'm out of breath, so. For the record, Delegate Michelle Guyton, District 42B in Baltimore County, and I am here to ask you and thank you for your consideration of House Bill 1244 to establish the Maryland Developmental Disabilities Administration Waiver Advisory Council in state law. I can't say it 3 times fast, but hopefully you all can see it written down. The council already exists, all right? So this is something very important, and I know that Madam Chair understands why we're doing it this way. I cannot thank Madam Chair, Madam Vice Chair, whom I don't see at the moment, and especially Delegate Bagnall for really spending a great deal of time trying to address some of the issues facing our citizens with developmental disabilities and helping me work out a way so that this bill could come in, be effective, and not cost any money. So this is a very good combination. Right? So the council already exists as a requirement, as a federal requirement for Medicaid. So the Developmental Disability Administration has started the meetings. I believe they've had 2 at this point. And what we have decided to do is to establish the council not just in the department informally, but in Maryland law. Right? And by doing so, we can empower our state to influence not only the membership, which this bill does to some extent, but also address the unique concerns that all of you have heard, if you've been sitting in this committee, from the members of our disability community over the past year. Right? So I wanted to share just a moment with you, a few little items, because I know that you're probably all going to read every line of every piece of mail that you get, but just in case you don't get through the entire file, I wanted to highlight just a few things that some of our constituents have written in support of this bill and why we need to address the problem. So recent changes to policies published in November 2024 without public input and with no warning has created chaos and confusion for participants. I would say that's fairly accurate. Over the last year, Maryland Department has grown Maryland Down Syndrome Association has grown increasingly troubled by the DDA's lack of meaningful stakeholder engagement with participants. Right? They also say that the way that things have been handled and the tenor of the communication from DDA this year have been confrontational, accusatory, and disrespectful of individuals with developmental disabilities who are entitled to services. Right? And then finally, collaborative problem solving is sorely needed to ensure the strength, stability, and sustainability of the Medicaid waiver programs. There are a whole lot of other lines of support in your folder, and I hope you will take a look at them. But certainly, this is more important than ever because it is possible, we all know anything is possible in this federal landscape, that there might be a potential loss of funding and guidance from our federal administration when it comes to Medicaid, right? And so because of that, putting this advisory council into state law so that we can impact the direction that it takes is more important than ever. So a few changes to the council that is already in existence that we put into this bill are the addition of several members, and I'm sure you have the bill in front of you, and enforceable guidance to the council that expands their work to include collaboration, communication, feedback to both their constituency and to us in the General Assembly, which is something that did not exist before. So I hope that you please consider a favorable report on House Bill 1244 to support the disabilities community and the DDA in their efforts to work together to better work together to improve the system in Maryland to support of all of our constituents. I do have one amendment that is a sponsor amendment that is truly technical. It changes a word so that it is clear that no, we're not asking for people who are working for the ARC or MAX to be on the council, but actually a representative from those groups. And then there are a couple of other amendments that will come before you, one of which is very interesting. It is not my amendment, but I hope maybe there can possibly be some conversation about it that puts a little more teeth into this piece of legislation, and I would certainly be in favor of that if it's possible. So thank you very much.
You're welcome. Who you like to go next?
Okay, I guess I'm starting. Good afternoon, Madam Chair, members of the committee. I'm Rachel London, the Executive Director of the Maryland Developmental Disabilities Council and the Chair of the Maryland Developmental Disabilities Coalition. You have our written testimony, and both organizations are supporting with the sponsors' amendments that she just spoke about. Thank you so much. I'm also a member of the Waiver Advisory Council, and we have met 3 times. It is in existence, but House Bill 1244 is important, as Delegate Guyton just mentioned, because not only does it put it in statute, but it adds key stakeholders and provides a bit more structure and requirements for the advisory council. I want to highlight 2 critical parts, the advisory council and the legislation. First, I'm going to stress the fact that the purpose of the advisory council is to make recommendations about the waivers, the DDA Medicaid waivers, and service delivery, which happens in 2 models. It happens in self-directed services, and it happens through the community provider model. Over 18,000 people with developmental disabilities receive services in both models, about 15,000 people from community providers, and almost 4,000 who self-direct their services. And this committee will continue, and with a little bit more purpose and recommendations is to look at both of those models through the waiver. Second, when the advisory council is fully has all of its members, it is a majority of people with lived experience, and that is critical. We strongly support that. In fact, my council is also a majority of people with lived experience. The sponsors' amendments do keep that membership aligned with having a majority of people with lived experiences. Madam Chair, for all of those reasons, we are in strong support with the sponsors' amendments. Thank you.
You're welcome. And nice to see you, Rachel.
Nice to see you.
Who's next?
Can we go? Good afternoon, Madam Chair Pena-Melnick and members of the committee. My name is Andy Kalp, and I'm the Executive Director of the ARC Maryland, and I'm here in support of House Bill 1244 as amended by the sponsor. For those of you who don't know, the ARC is a statewide advocacy organization that's dedicated to protecting and advancing the rights of people with intellectual and developmental disabilities and supporting their families. We advocate for the viability of all with a lens on quality, efficiency, informed choice, modernization, and sustainability. And we've been heavily committed to doing this work since the 1950s when we were started. And in fact, the ARC has been behind many important pieces of legislation, civil rights legislation that have passed not only on a state level, but also on a federal level, such as the IDEA and the Americans with Disabilities Act. So we've been around a long time and have helped get these things in place for people with intellectual and developmental disabilities. I want to speak for a second to the amendments that have been proposed. If you look at the bill, it was page 3 or 4, the ARC and MAX were listed in the wrong section. So what the amendment does is move us up to the specifically named advocacy organization area of the bill because it says providers, licensed and certified providers of the ARC Maryland. The ARC Maryland isn't a licensed and certified provider. We are a statewide advocacy organization, so that's where our membership would fall. And in the fiscal note on the back page, it inaccurately says that people would have to lose their seats on the council if the ARC is added. But because we're not a licensed or certified provider, we won't be upsetting anyone else off the council by our inclusion on this council. So for all those reasons, I respectfully ask for a favorable report on this bill. Thank you.
Thank you for your testimony today. We appreciate it. Who would like to go next?
Good afternoon, Madam Chair, members of the committee. I'm Laura Hallam, the CEO of MACS, the Maryland Association of Community Services. We are a statewide nonprofit association of 125 community providers across the state of Maryland, and we're here in support of House Bill 1244. We greatly appreciate the sponsors' work to codify this important group that ensures well-rounded stakeholder representation to advise DDA on the many aspects of policy that relate to the 3 DDA waivers. We also greatly appreciate the sponsors' clarifying amendment to include MACS and the ARC Maryland on the council. The vast majority of DD services offered by community providers are provided by MACS members. So by including us, it ensures a broad provider perspective that cuts across all regions of the state, all sizes of providers, and all waiver services. And I just want to thank you, Madam Chair, and the members of the committee for your longstanding support for Marylanders with developmental disabilities and community providers. And with that, we urge a favorable report. Thank you.
Thank you very much. Who's next?
Hi, my name is Alicia Wopat. I'm with the Self-Directed Advocacy Network of Maryland. We're a group of people who advocate for those who self-directed their DDA services, and we're delighted to be here today in support of the sponsors Bill 1244. We wholeheartedly support this because we feel it's the codification, is that a word? Codification is really important, and the fact that it includes a much broader range of advocates and people with lived experiences is a change for the better, as well as the very high level of consensus building that this bill requires. So for those reasons, we feel it's a significant improvement and look for your favorable report. Thank you.
And thank you for being here. Thank you for all the work that you all do. It is, I know it's a tough job, okay? I hope that you feel the support from the committee. All right?
Absolutely.
I'm
Thank
going to
you.
open it up for questions now. I don't see any. That doesn't mean we don't care. It just means that you worked hard on drafting the bill with us ahead of time, which really makes a difference. It is now going to be assigned to a subcommittee, and I welcome you to come, and we'll get it done.
Thank you, Madam Chair. Thank you,
My pleasure.
committee.
Next, we have Adam Wyndham, Ann Learborn, Kirill Resnick, Shari Dexter, and Alaris Vidal de Palacios. And I do have, just for the record, a letter from Katie Yatabi. Are you here? I know you did not get to sign up on time. I think you're here, right? It's Katrina Yatabi? Yes, I have your letter, okay?
I think I'd just like the written testimony.
Yes, I have it.
Okay.
All right, thank you. Go ahead. Good afternoon, everyone. How are you? Nice to see you, Delegate Resnick.
Nice to be seen. Good to see everyone here.
Yeah. There's a saying that says in Spanish, dichoso los ojos que te ven. Lucky or blessed the eyes to see you. I haven't seen you in a while.
Long time.
You're doing all right. Go ahead. You can get started.
Well, thank you, Madam Chair, members of HGO. Thank you for the opportunity to testify on HB 1053. I'm here favorable with amendment. My name is Kirill Resnick, and I am here on behalf of the Concerned Citizens of Self-Direction, a participant and family advocacy group supporting self-direction for Marylanders with intellectual and developmental disabilities. This legislation is absolutely necessary, and the members of CCDS want to see the establishment of the DDA Waiver Advisory Council set in code. The participants, parents, family members, and providers of DDA services, especially those in the self-direction program, want to have a voice in the process of decision-making as a partner to Maryland State Government, the Department of Health, and the Developmental Disabilities Administration. So for those reasons, we asked the bill to pass and the advisory committee to be established. We have, however, proposed an amendment which is included in my submitted materials and which Delegate Guyton had referenced. This amendment would give the council the ability to review and approve any proposed amendment requests for the 3 Medicaid waivers most relevant to the intellectual and developmental disabilities community. With this change, participants who are affected by the IDD waivers will have a real voice in how the policy is determined. I will now turn it over to Ann Vleerborn, a member of the CCDS steering committee and a parent of a self-direction participant, and I ask the committee for a favorable vote with amendment. Thank you.
Thank you for being here. You can get started.
Hi, my name is Ann Valerbone. As Krill said, I'm the parent of a 34-year-old son, Michael, who has autism and is developmentally delayed. Michael has successfully participated in self-directed services for the last 13 years. When Michael started with the waiver, by law, it did and does give employment and budget authority to the participant. The Community Pathways waiver is required to do this to be in compliance with CMS rules. We created a team from Michael, a service coordinator, a support broker, vendors, employees, and my recently deceased husband and myself. We all had the goal of creating a meaningful, safe plan for Michael to thrive in his community. And we did just that. Michael has had vendors and staff that have worked for him for most of that time. Prior to January of 2024, there were periodic issues with DDA, but we were able to communicate and resolve the matters that arose. However, since that time, there has been little to no communication when problems are found. Calls are not returned, emails go unanswered, and denials of services and budget authority are not communicated in writing, meaning we cannot file appeals. These problems began prior to the October 2024 as a self-directed service manual. However, they are so much worse now. We have been preparing for this meeting for several days. I'm a part of the group, Concerned Citizens for Self-Directed Services Maryland, only to randomly discover a new version of the manual was published on Friday, February 28th, that went into effect Saturday, March 1st. This manual is 120 pages. By published, I mean that it was posted on DDA's website. Not one participant, provider, service coordinator, support broker, or vendor was notified directly of the changes that precisely affect the participants. The Deputy Secretary spoke at the House Appropriations Committee on that Friday afternoon. It would have been an ideal forum for the announcement that DDA had heard our voices and were considering our opinions. It was, however, a perfect example of the continued lack of team input and DDA's lack of communication with the very people we are counting on to care for our loved ones. Suddenly losing my husband, Michael's father, has made me acutely aware of the fact that I will not always be here to fight for my son's civil rights. And what will become of him if the government that signed a contract with him to provide his level of necessary care changes their minds and to balance a budget? We need to be a meaningful part of the advisory council that is being proposed today. This council is a CMS requirement. Our ask is that these members be appointed by Governor Moore and not the Secretary of Health. We need the flexibility of true budget and employer authority because, like in my situation, Michael needs to pay an enhanced rate due to his size, strength, and behaviors. Each participant relies on individually determined levels of care and differing services. DDA has signed contracts with our participants that acknowledge those needs and levels of services. Please help us have a seat at the table. We welcome any questions at any time. Thank you.
And thank you for sharing your personal story, and so sorry to hear about your husband's passing.
Thank you.
Okay, next, please.
Thank you so much, Madam Chair and members of the committee. I'm Sherry Dexter, and I am also with Kirill and with Ann with Concerned Citizens of direction for Maryland. Wanted to just say, I'm going to make this really easy on you, that I concur with my colleagues here, so we'll make it short and sweet. But I also really wanted to thank Delegate Guyton, because it does sound like she is open to the amendment that we are proposing. As Ann noted, we have been through so much in such a short amount that truly families are, all of these changes are wreaking havoc, and they're happening almost daily, it feels like. Please help us. Please help us have a strong voice, and one that we can be sure of what is happening in the future. So we appreciate your support, and we hope that everybody is open to the amendment that we are proposing, and we appreciate your support.
And thank you for being here. We appreciate you. Adam?
Good afternoon, Chair and members of the committee. My name is Adam Wyndham, and I'm here today as a parent, advocate, and caregiver for my daughter with disabilities. I'm urging you to support HB 1244, which would establish a Developmental Disabilities Administration Waiver Advisory Council that is objective, transparent, and truly representative of those impacted by DDA policies. Families, self-advocates, and stakeholders, I am urging you to support HB 1244 and would like to offer a friendly amendment which would establish the council. Families, self-advocates, and stakeholders deserve a council that serves their interests. One of the major concerns with DDA's previous council was the significant exclusion of family members from the decision-making. Out of 33 seats, only 4 were selected to be family members. DDA removed family members from the definition of lived experience, despite federal precedent recognizing that family members are a critical part of the disability community. All other definitions I've seen amongst federal agencies and national advocacy organizations include family members in the definition of those with lived experience. For example, in the DDA recruitment email for this council, it stated, "We especially encourage individuals with intellectual and developmental disabilities to apply. The Waiver Advisory Council will be composed primarily of members with lived experiences, including current and former participants in DDA-operated Medicaid waiver programs." Then in the application itself, it further defined, "This council will include a majority of people with intellectual and developmental disabilities with lived experiences," and in parentheses, defined current and past DDA participants as self-advocates. By removing family members from the definition, DDA is effectively excluding many of the people who advocate daily, navigate the bureaucracy, and provide direct care for individuals with severe disabilities. Families are a vital part of the waiver system, and their voices must be included. To ensure true representation, I would like to offer a friendly amendment be made to HB 1244 to formally define lived experience to include family members of individuals with disabilities. This will prevent future exclusion of family members and ensure the policy decisions reflect realities faced by the entire disability community. Thank you.
Thank you, and nice to see you.
Thank you.
Thank you for your testimony on the other bill. You saw that it went through.
Yes, ma'am. Thank you.
Wonderful. Next, please. How are you?
Hi.
Nice to see you.
Madam Chair, always good to see you.
Thank you.
My name is Alaris Vidal de Palacios, and this is our formal request for inclusion on the advisory board for HB 1244. The Maryland Council of Support Brokers formally requests to be considered for a seat on the board currently formed underneath of this bill. As the only professional firm with active representation and engagement in the state's support broker community, we believe our participation is essential to ensuring balanced and informed advocacy for self-directed services in Maryland. The Maryland Council of Support Brokers, a professional organization representing the interests of support brokers, families, and stakeholders in the state's waiver option for self-directed program alike, has been in existence since 2022, with over 400 certified support brokers representing the state's over 4,000 participants. Support brokers are certified by the Developmental Disability Administration. The Maryland Council of Support Brokers has consistently worked to uphold the standards and integrity of support broker services. Our organization has provided critical support through providing referral services for families seeking assistance from support brokers, hosting monthly meetings and training sessions for support brokers statewide, providing advocacy and support for approved and new families who have questions about waiver services, watchdown services for regulations which shift and change the mannerisms and how services are delivered. Collaboration with other recognized community organizations include ESTAN, Maryland Task Force, Montgomery Transitional Work Groups, etc. We also, when there was a larger issue in 2023 with payments from the FMCSs that had been brought into the state, we advocated and were able to secure millions of dollars, participate in the securement of millions of dollars. In light of our established presence and expertise in the self-directed services community, we respectfully request that the Maryland Council of Support Brokers be granted a seat on the board. Excluding our organization from this critical initiative would diminish the inclusivity and representational balance necessary for meaningful decision-making. Failing to include the Maryland Council of Support Brokers would eliminate representation of over 400 support brokers and more than 4,000 families who participate in self-directed services. These families rely on support brokers as their personally selected advocates, whereas other representatives, such as CCSs, are assigned and act as agents of the administration. Support brokers have an intimate understanding of the internal processes that the self-directed families navigate daily. Ignoring this group denies the voices of those most directly affected by these recent service changes and undermines the integrity of the advocacy process. Thank you.
You're welcome. All right, I'm going to open it up for questions now for this panel. Are there any questions? All right, thank you so much. Good job.
Thank you.
You're welcome. And this actually concludes the bill hearing on House Bill 1244. Next, we are going to do Delegate Bagnall, 1142. Public Health Maryland Interested Party Advisory Group Establishment. I don't see Buckle. You see Buckle yet? No, I got a text that he's voting. It hasn't worked? The timer's not working? He's voting. Oh, that's okay, so I'll push it to later. He can take his time, not stress. Thank you for letting me know. House Bill 1142. Public Health Maryland Interested Party Advisory Group Establishment. Can you get started, please?
Good afternoon, Madam Chair, Madam Vice Chair, and members of the Health and Government Operations Committee. For the record, I'm Delegate Heather Bagnall, District 33C, Anne Arundel County. Very excited to be here in support of House Bill 1142. Direct care workers are a pillar of Maryland's health system. These are the workers who provide home care and community health services for our state's residents with disabilities and our aging population. Despite being an essential part of our workforce, our direct care workforce is struggling to meet our state's need. And we often are often the last at the table to receive assistance and recognition for their work. The federal government recognizes this. The Centers for Medicaid and Medicare Services recently released the Ensuring Access to Medicaid Services Final Rule, also known as the Access Rule. Among the provisions of this rule, states are required to establish an interested parties advisory group of direct care workers and other interested parties in home and community-based services. Through this advisory group, direct care workers will provide much-needed advice on reimbursement rates and other CMS policy affecting their workforce. The goal of this advisory group is very much in line with the work that this committee has accomplished to uplift our home care and community health workers. Under the Access Rule, each state must convene an interested parties advisory group by 2027. It will take time for recommendations to equate to real action, so House Bill 1142 allows Maryland to begin work on implementing this advisory group now, so we can see real change for our direct care workers as soon as possible. With this bill, we have an opportunity to continue our work to stabilize the direct care workforce, improve pay transparency to direct care workers, and increase choice for Marylanders who rely on direct care workers. Maryland should not wait until 2027 to improve our direct care workforce. Now, I've worked with the department and our stakeholders, and we have requested consensus amendments which will alleviate the fiscal note and ensure everyone has a seat at the table and that Maryland continues to lead the way. With that, I ask for a favorable report on House Bill 1142 because it will give our state a head start, and I will turn it over to my esteemed panel.
I'd like to go next.
I can go next.
Thank you.
So, hello, Chair, Vice Chair, members of the committee. My name is Allison Yunda, and I'm here on behalf of the National Domestic Workers Alliance. And we are here to submit testimony in support of HB 1142 to establish the Maryland Interest Parties Advisory Group. NDWA is a leading voice for the estimated 2.2 million domestic workers. That includes nannies, house cleaners, and home care workers. And while we are a national organization, our DMV chapter is a locally operated membership-based organization. HB 1142 establishes the IPAG, or Interest Parties Advisory Group, within the Maryland Department of Health as mandated by federal law. This group will include representatives from direct care workers and consumers and will provide key recommendations to the state on improving provider payment rates for home care services, focusing on the wages and working conditions of direct care workers. The demand for home health and personal care aides will continue to rise over the next couple of years, and as an organizer, I talk to home care workers every day, and I know that while many of them love their jobs, they're thinking about leaving this field because of the working conditions that they face. So HB 1142 provides a framework and mandate to the Maryland Department of Health to establish a robust IPAC that allows for meaningful participation of the direct care workforce, helps ensure that Maryland takes action to set Medicaid rates high enough for sufficient wages, analyzes other issues facing the workforce, and gives workers a voice to provide strong recommendations to policymakers on how the state can raise rates in order to improve working conditions. As our population ages and the demand for home and community-based service sharply rises, without policy intervention that takes into consideration those that are directly impacted, Marylanders will be left to fend for themselves and their loved ones. So for these reasons, NDWA fully supports HB 1142, the Interest Parties Advisory Group. Thank you.
Next, please.
Chair, Vice Chair, members of the committee, it's good to see you all. For the record, Ryan Moran, Acting Secretary of Health. I just want to take a couple of moments and talk a little bit about what this bill does from the federal perspective, from the CMS realm of this. As the sponsor articulated, there is a provision within recent federal requirements that brings together what's called an interested party advisory group that is its main focus is to really look at the payment rate adequacy related to Medicaid rates for home and community-based services. Therefore, then creates an interested parties advisory group with latitude from the particular states to come together and understand what are some of the ways in which those organizations can advise as appropriate. With that being said, I want to talk a little bit about some of the amendments that we have made to this bill. The first is the scope of this particular group to make sure that they align with the federal requirements as we stand this work up. The second is taking a look at membership, not only from a direct care worker perspective, but also a provider association, adding in our colleagues from the Department of Labor and ensuring that the department is representative. Third, ensuring that we have annual meetings related to this particular group. And fourth, in good government ways, ensuring that we're transparent about the work that we're doing, publishing to our website, the reporting and the aspects that are happening. As the sponsor mentioned, we've worked hard in terms of those particular amendments to zero out the particular fiscal note and are looking forward to this particular work ahead as it relates to standing up Maryland's Interested Parties Advisory Group in the future. And with that, support with favorable amendments.
Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. For the record, Megan Peters here for the Alzheimer's Association in support of House Bill 1142. For many people living with dementia, there will come a time when they will need more care than an informal family caregiver can provide. And many of those times, it will come in the shape of home and community-based services. We know these services are vital to keeping people living in the community as long as possible. And HB 1142 is an important bill that will codify and add to the federally required Interested Parties Advisory Group, which aims to ensure access to these services and assess direct care workforce adequacy. Today, 1 in 3 people using home health services has Alzheimer's or another dementia. And the largest segment of the workforce supporting these people is the direct care workforce. We know the demand on these workers will grow as our population ages, and we need to support these workers with better wages and supports. House Bill 1142 will help by prioritizing the perspective of workers as well as consumers, like people living with dementia or their caregivers, on recommendations for Medicaid payment rates. Bringing in these perspectives is critical to enable informed policy and help Maryland recruit and retain these critical workers, and therefore the Alzheimer's Association supports House Bill 1142 and urges a favorable report. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is David Rodwin from the public interest law firm of Murphy Anderson PLLC. I'm very happy to be here today to testify in favor of HB 1142 and grateful to Delegate Bagnall for championing this legislation. This bill is about getting Maryland ahead of the curve in implementing this new CMS requirement for an interested parties advisory group. It builds on the sort of bare bones structure that's set out in the rule. It has the meetings be more frequent. Under the federal rule, the minimum is once every 2 years. We're very grateful to the acting secretary and the department for working with us on having that be more frequent to annual meetings. It builds on the structure in other ways too, making it a really meaningful way for those most impacted, direct care workers, as well as those they care for, having their voices heard when policymakers are setting the policies that have such a great influence on their daily lives and the quality of their life. Also very happy to just reiterate that with the amendments, it zeroes out the fiscal note. So there is a zero fiscal note right now. And finally, under the federal requirement, the required members on the Interested Parties Advisory Group are workers, people who receive care, and their authorized representatives and others. In an exercise of good faith, we put in the bill that employer representative is also on it. And under the amended bill, there's actually 2 employer representatives. So just wanted to make that clear as well. And with that, we ask for a favorable report. Thank you so much.
Thank you. I see Claudia Baglag. Is she not here? Okay. Yeah. Okay.
Thank you, Madam Chair.
You're welcome.
Sorry. Good afternoon, Chair Pena-Melnick, Vice Chair Collison, and members of the committee. My name is Claudia Balog. I'm the Assistant Director of Research with 1199 SEIU. We have 450,000 members across the country. We're the largest healthcare workers union in the country and a proud partner of with Caring Across Maryland and a strong supporter of HB 1142. So in creating the IPAG, we're going to ensure that all stakeholders have a seat at the table, but most importantly, the direct care workers who will be given the power to help address provider rates. And as everyone at this table has stated, those provider rates being adequate is critical to addressing the low pay in the industry that undergirds the massive workforce shortages. So 1199 members, we work in hospitals, in nursing homes, in clinics. We work in the overcrowded Maryland emergency departments and the short-staffed nursing facilities. Our members see every day what happens when Marylanders need higher acuity care. That's a result of the care gaps in home care or their inability to secure those services to begin with. So they see what we know, which is how our total cost of care model needs strong healthcare delivery across the care continuum. The Medicaid access rule includes the IPAG requirement in every state because CMS recognized how low wages are impeding that access to care. And they also recognize that worker voices are key to solving the problem. This administration inherited a massive wait list for home and community-based services. As many as 26,000 residents have been waiting for help. The workers closest to the problem are also closest to the solutions to address these staffing shortages. Passing this bill is especially important as we face potential Medicaid cuts, so we strongly encourage a favorable vote on HB 1142. Thank you for your consideration.
Thank you for being here. So let's open it up for questions now. Are there any questions for the sponsor of the bill and her panel? No? I did have a question, and it was the fiscal note. It's a little shocking. So you have dealt with it. And are we getting a letter, a new letter or something for the subcommittee? Okay, wonderful. Thank you so much. All right, let's move on to Sandy Ballin. Isata Kaba. Actually, no, just say where you are. Let me go with the unfavorable first. Let me be balanced. And when you testify with the amendments that you heard. Let us know, the committee know how you are there. Donna Kaufman, And we have Deborah Brocado. Can you bring Deborah Brocado up, please? And that is unfavorable. Go ahead.
Madam Chair, Madam Vice Chair, members of the committee, for the record, I'm Dana Kaufman. I'm here on behalf of Maryland National Capital Home Care Association. We are favorable with amendments. We had not, when I had to sign up, we had not received the amendments yet. The amendments, as you will see, are very substantial, and they do take care of the concerns that we raised as well with the discrepancies in what the federal law required and what was in the in this bill. However, we still do have one concern, and that is with the composition. The amendments basically, for the composition, they are 3 consumers, 2 representatives of consumer organizations, 3 direct care workers, 2 reps of associations of direct care workers, and then just 2 reps from provider associations. The RSAs are the ones who hire the direct care workers for the most part, and they participate in the Medicaid program, and we have said it over and over again that the entire system is underfunded. And it is those providers who are also dealing with so many of the regulatory requirements and the additional burdens. And I will also say, you know, because I always think that this is important to say, they have a lot of unfunded mandates on them, and they understand the entirety of this situation. And we do think, since this is an advisory council, that we should also have 3 provider, actual provider representatives, like from the residential service agencies or from other components, since this might affect more than just home care. But we do think, as an advisory council, this needs to be better aligned. And really, we have to start looking at our residential service agencies and our providers as partners in this mission. So with that, I would ask for your favorable with that change to the composition. Thank you.
Okay, are there any questions? Okay, thank you so much, appreciate it. And can we go to the virtual witness, Ms. Brocado? Good afternoon, and you can get started.
Okay, good afternoon. I'm Deborah Brocado with Maryland Right to Life. On behalf of our board of directors and followers across the state, Maryland Right to Life asked for an amendment to exclude abortion purposes from House Bill 1142. The advisory committee from this bill will evaluate access to home and community-based services and the amount of workforce for those services. We need improved healthcare delivery, but let's not allow appropriations created from this bill to be directed toward the abortion industry. Maryland taxpayers already pay millions of dollars for abortion services, while other health matters go unfunded and ignored. The Abortion Care Access Act provided Medicaid and private insurance funding of abortion and a perpetual training fund. There are many other programs that do the same, and a list is in my written testimony. Medical scarcity is not solved with more abortion training and more abortion workers. Maryland Right to Life supports better availability of healthcare services. Abortion services on every corner and in every home are not the way to do that. We ask for an amendment to exclude abortion purposes from this bill so that members of the abortion industry are not on the advisory committee. The bill is not used to staff or provide training for the abortion workforce, not used to provide clients for the abortion industry, and not used to further promote and provide abortion services. Marylanders have so many other health concerns, including but not limited to diabetes, wound care, weight management, heart disease, lung disease, post-operative care, and the list goes on. We need to prioritize these chronic conditions, which could be addressed very well with home care and community clinics. With so many other laws and programs that already fund abortion, let this bill be separate and apart to address the endless list of serious health conditions. The budget deficit shows resources are limited. More funding and resources directed toward abortion means less funding and resources for other healthcare concerns. For these reasons, we respectfully ask for an amendment to exclude abortion purposes. Without the amendment, we urge an unfavorable report on House Bill 1142. Thank you.
Thank you. Are there any questions for this witness? Seeing none, thank you very much. So now let's go back to the favorable. If I may have the following people, please. Sandy Ballin, Isada Kaba, Rafael Lacayo, Sam Williamson, and Tommy Bresnahan. Those are the last witnesses for this bill. Then we're going to go on to Delegate Pipi, because it's just you, and then Buckle. You can have a seat, and can you get started, please? Someone.
Short.
Thank you.
Good afternoon, Chair Pena-Melnick, Vice Chair Cullison, and members of the committee. My name is Sam Williamson. I'm an attorney with the Public Justice Center, and I'm here in support of HB 1142 with sponsor amendments. This bill is an important step forward towards improving wages for our direct care workforce. In 2023, Medicaid-funded workers typically only earned $14,600 per year when working on the Eastern Shore and $28,000 per year in the Capital Region. These wages are significantly behind wages for jobs with similar or lower entry-level requirements, lagging $2.28 per hour behind those comparable or easier-to-obtain jobs. Low compensation is the #1 reason that Maryland is struggling to retain its direct care workforce, and without enough workers, consumers are struggling to get the support that they need. Our Medicaid reimbursement rates are currently too low, and only a portion of those rates actually translates into wages for the workers. By creating an advisory group that is informed by worker and consumer experiences, we can put Maryland in a better position to attract and retain these key workers. Employer representatives are not required under the federal access rule. The purpose under the CMS rule is to ensure that worker and consumer voices are representative, and we're in favor of maintaining the 2 employer spots in the sponsor amendments. For these reasons, the Public Justice Center urges a favorable report on HB 1142. Thank you.
Thank you, and thank you for being here. Next, please.
Good afternoon, Chair, Vice Chair, and members
Will
of the
you
committee.
be so kind and move the microphone closer to you? Thank you.
Good afternoon, Chair, Vice Chair, and members of the committee. My name is Isa Takaba, and I'm members of the National Domestic Worker Alliance. I've been a direct care worker for 17 years, and this work means everything to me. It all started when I took care of my grandma back in Africa. From there, I decided to pursue this career over the years. I've earned my CNA, to name a few, CNA, first aid, and safety precaution, and gain experiences with patients dealing with dementia, Parkinson, and end of life. But my favorite part about my job is the relationship I built with patients. This job requires patient care and kindness, quality that I am proud of. However, the challenges are real. We don't always have security in this job. Direct care workers are unpaid. Agencies start at $15 per hour. For that, $15 per hour. We work long, emotionally draining hours. I have to work multiple jobs just to make ends meet, and I can't afford time off when I'm sick. I believe home care workers need a voice because no one understands our job like we do. We are on the front lines providing essential care, and we deserve to be heard. Our patients are Medicaid recipients, but even though the Maryland government supports the Medicaid program, they do not hear directly from us on the ground providing the care. Only our employee and agencies. We need better wages, security, and recommendation from the vital work we do. If our working conditions improve, I know we can offer even better care to our patients. We deserve to sit on the table to shape the future of home care, especially the Medicaid payment rate that determine our wages and benefits in this job. For this reason, I urge the community to vote in favor for HB 1142 interest parties groups, so home care workers have a voice in the decision that impact us. Thank you.
Thank you. Next, please.
Good afternoon, Madam Chair, Madam Vice Chair, and committee members, and thank you for the opportunity to speak today in support of House Bill 1142. My name is Sandy Ballin, and I am a staff attorney at Disability Rights Maryland. We are the federally designated protection and advocacy agency in Maryland, mandated under federal law to advance the civil rights of people with disabilities. The development of home and community-based services served as a critical turning point in ensuring that individuals with disabilities have a choice in where they could receive their care. DRM clients often rely on direct care workers to provide them with essential care and assistance within the comfort of their own home. Direct care workers' concerns, though, about working conditions are commonly ignored, leading many to leave the workforce for better conditions and creating a shortage of home care workers. Such a barrier makes it difficult for individuals with disabilities to access the care that they not only need to thrive within the community, but also just survive. House Bill 1142 will ensure that this barrier to accessing quality care in Maryland is addressed and resolved. With a more stable direct care workforce, consumers who rely so heavily on these workers can have access to the quality care that they're entitled to. The ability to access such necessary and quality health care without barriers is essential in ensuring that all individuals can lead the life they want and deserve. Unfortunately, the various barriers within the current healthcare system prevent individuals with disabilities from doing so. House Bill 1142 can ensure that Maryland is a part of the solution to breaking down those barriers and can help to create a future that allows people with disabilities to feel respected and equal in society. For these very reasons, Disability Rights Maryland strongly supports House Bill 1142 and urges a favorable report. Thank you.
Thank you. Next, please.
Mr. Lacayo will be testifying in Spanish, so I'm going to interpret for him, and I believe we communicated previously about giving slightly extra time since it'll be interpreted.
Okay.
Muy buenas tardes, honorables miembros de la Cámara de Delegados. Mi nombre es Rafael Lacayo, soy cuidador de adulto mayor y miembro de la Alianza Nacional de Trabajadores del Hogar. Hoy quiero hablar en nombre de los héroes invisibles que dedicamos nuestras vidas, tiempo, amor y energía a cuidar de nuestros adultos mayores. Nuestra labor es más que un trabajo, es un acto de amor inigualable, un compromiso profundo con la dignidad y el bienestar de quienes alguna vez nos cuidaron a nosotros.
Good afternoon, honorable members of the House of Delegates. My name is Rafael Lacayo. I'm a caregiver for older adults and a member of the National Domestic Workers Alliance. Today, I want to speak on behalf of the invisible heroes who dedicate our lives, time, love, and energy to caring for older adults. Our work is more than a job. It is an act of unmatched love, a deep commitment to the dignity and well-being of those who once cared for us.
Hemos sido faros de luz en los días oscuros para nuestros adultos mayores, brindando consuelo, apoyo, compañía y amor a aquellos que a menudo se sienten olvidados y acabados. Nuestra presencia amorosa marca la diferencia en la calidad de la vida de los adultos mayores, ya que enriquece sus días con amor y dignidad. A pesar de los desafíos y sacrificios que enfrentamos a diario, seguimos adelante con valentía y compasión. Más líderes de Maryland que tienen el poder de cambiar las condiciones laborales de cuidadores necesitan escuchar estas historias. Necesitan escuchar directamente de nosotros, los trabajadores, sobre nuestros desafíos y nuestras soluciones para hacer que estos trabajos sean buenos trabajos.
We have been beacons of light in the dark for the dark days of older adults, providing comfort, support, companionship, and love to those who often feel forgotten and finished. Our loving presence makes a difference in the quality of life of older adults as it enriches their days with love and dignity. Despite the challenges and sacrifices we face daily, we continue to move forward with courage and compassion. More Maryland leaders who have the power to change the working conditions of caregivers need to hear these stories. They need to hear directly from us, the workers, about our challenges and our solutions to make these jobs good jobs.
Por eso venimos a levantar nuestras voces para dirigirnos a nuestros legisladores para que nos apoyen en la propuesta de ley HB 1142 para crear un IPAC que está en este comité hoy. Una estructura como esta que reunirá a los directamente afectados, proporcionará mejores recomendaciones que las que los políticos pueden idear por sí mismos, porque se basa en la experiencia directa de trabajadores como nosotros y pacientes que reciben cuidado.
This is why we come today to raise our voice, to address our legislator to support us in this bill, HB 1142, to create an IPAG, which is in this committee today. A structure like this will bring together those directly affected, will provide better recommendations than politicians can come up with on their own, because it's based on the direct experience of workers like us and patients who receive care.
Por estas razones, apoyamos plenamente la ley HB 1142 del Grupo Asesor de las Partes de Interés de Maryland. Gracias, honorables legisladores, por su atención y esperamos contar con su apoyo y voto favorable para brindar una calidad de vida a nuestros adultos mayores que ellos realmente se lo merecen.
For these reasons, I fully support HB 1142, the Maryland Interested Parties Advisory Group. Thank you, honorable legislators, for your attention, and we look forward to your support and favorable vote to provide a quality of life for our seniors. seniors that they deserve.
Thank you. Thank you for your testimony. So we're going to open it up for questions now. Any questions? Seeing none, thank you very much. The last witness we have is Tammy Bresnahan. Are you here? Tammy? No? Not here? So basically, this concludes the bill hearing on House Bill 1142. I have to step aside for a meeting that I have with the governor's office. This is the order for now. It is Delegate Pippi, and I believe you're the only witness. Can you come up, please, on 1109, Public Health, Consumer Protection Act. And then after that, Delegate Buckle, you will be next, okay?
Thank you,
My pleasure. And Vice Chair Collison will take over for now. And Delegate Pippi, welcome to the committee.
Thank you.
How are you?
Very well. Thanks for having me.
Okay.
So I'll get started. So Madam Chair, Madam Vice Chair, and honorable committee members, Delegate Pippi, for the record, in support of HB 1109. This bill deals with the ongoing opioid crisis. So what you've seen in the news lately is that some of the heroin incidents have gone down, but what you haven't seen is that individuals overdosing, usually related to heroin, but including xylazine and medetomidine, which are two animal tranquilizers that are found overwhelmingly in most heroin overdoses, and a lot of heroin overdoses. Let me give you an example. In 2021, there were 354 heroin overdoses in Maryland, but there was 575 overdoses related to xylazine and medetomidine. Again, these are animal tranquilizers that are now being used, and there's a street name for it. They're called trank, but they are basically mixing that in with heroin and fentanyl. Every single state that surrounds Maryland has scheduled these drugs. Every single one. Pennsylvania, Delaware, Ohio, West Virginia, Virginia, because they've recognized the seriousness of these. By the way, they're also resistant to naloxone. So you think about how far we've come, where you have somebody that has overdosed, and we have medicine that can reverse that. These are resistance to that. So here's what the bill does. The bill, in lieu of scheduling, right, because we've been in ongoing conversations with the health department, in lieu of creating criminal penalties, what this does is this would prohibit the sale or distribution of these items other than for veterinary purposes, because they are still used for veterinary purposes as tranquilizers, mostly for canines, but it would prohibit the sale or transfer of these substances, and it would make it a civil penalty. It would be administered by the Attorney General's office. The Attorney General is in support of this legislation because they acknowledge how important this issue is. And then the money would go into the Substance Abuse Fund to support substance abuse throughout our state. And so when you guys have a second and you have a couple minutes to yourself, just Google xylazine and medetomidine. This is something that has crept underneath the radar. It's killing hundreds of Marylanders a year. It's making the ongoing battle against the opioid crisis ongoing, and I think we have an opportunity to do something about it. So happy to answer any substantive questions about the bill, and hopefully this committee would consider it favorable.
Thank you. So thank you very much, Delegate. Yeah. I'm going to open up for questions. Delegate Morgan. I almost called you Morgan.
I think those of us that represent rural areas are familiar with this stuff. They're animal tranquilizers. And you might not know this question. So a couple years ago, I thought we had a bill dealing with veterinarians and that would administer heavy drugs, and they had to input their the drugs they administer into the prescription drug monitoring program. Mm-hmm. Are these two drugs part of that? Is that a requirement, or?
So I don't know the answer to that. What I do know is that they're legal for veterinary purposes. Okay. They serve absolutely no purpose other than for veterinary purposes. This bill does not take that away from them because they are used, for example, with canines. But it's becoming a real issue because this is now the choice of either dealers or people that abuse heroin and other things, fentanyl. And if you look in your county, so we met with the state's attorney, we met with the sheriff's office. they're finding these substances in like 40% of the overdose deaths. I mean, it's unbelievable that like this has not been addressed before. And the fact that they're resistant to naloxone, you know, so you put your first responders on the scene, if they have this in them, they're not coming back. And like I pointed out, in 2021, there was 575 deaths related to this. Heroin deaths were only 354. So it's a serious issue. Our own local health officer is supportive of doing something. You know, look, the health department has the ability to schedule it. That's like the big ticket item. We're not even asking for that. All we're asking for is there's some sort of acknowledgement that individuals that do have possession of this, they're not passing that along to others. And this bill, I think, would clean that up. Again, the AG's in support, and the AG would actually be kind of administering this you know, the setup here where there'd be fines if somebody like a veterinarian or somebody was selling it to individuals for not veterinary purposes. But to your specific question, they might. I'm sure that that would probably be a requirement.
I had a couple colleagues shaking their head no.
No?
So,
okay. Well, there you go. That might be something.
Sounds like a good bill. Thank you for it.
Thank you for the
Appreciate
question.
it.
Thank you, Delegate. Delegate Taveras.
And thank you, Madam Chair. And I'm so surprised that we have things in common. But
what do you mean?
But this is actually something that I'm very in tune with as well, because I do have these issues as well in my district, and are fighting them as well on the street. So, have you investigated on what can detect these things, similar to our fentanyl detection strips? We can actually, have you investigated to see if there are any detection possibilities for xylazine? I mean, I saw them coming on the scene maybe about 2 or 3 years ago.
Sure.
But, and also for the prevention of naloxone, because I think people are just getting addicted, managing their addiction with naloxone, and they're managing, you know, their intake.
So, one, I appreciate you. This is an important issue that we could certainly work together on. But to kind of elaborate a little bit, so from 2012 to 2018, there were only 31 recorded xylazine-related deaths.
Yeah.
That's a long period of time, 31. Now, we're up to like several hundred.
Yeah.
You know, and so to whether it can be identified with some sort of test, it might be. I don't know the answer to that. What I'm hoping with this bill is at least to acknowledge, which you already know, we got to acknowledge the problem. And it's shocking to me that Maryland, we like went full steam ahead when it was fentanyl. When fentanyl came on scene and thousands of people were dying, we did everything, right? We added the 10-year kicker on penalties. Like if you knowingly sell fentanyl, it's an additional 10-year penalty. We did all sorts of stuff. What I'm saying with this here, and hopefully you appreciate, is we first have to acknowledge that this is an issue. And we're the only state that hasn't done that, because Pennsylvania, West Virginia, Ohio, Virginia, Delaware, every single state that we touch has scheduled these drugs. It's so bad that they're like, we're just going to schedule it. Maryland Health Department says, we're not sure if we want to do that yet. But this is a midway step to where we could say, look, you cannot, other than veterinary purposes, be giving this stuff out. Right now, there's no penalty. There's nothing. There's nothing to say you can't do it. And the fact that every time someone dies from an overdose, 30 to 40% of those individuals have these substances in them. I find that shocking, and it's in every county, including mine. It's a big deal. And so I'm hoping that we can do something this session with it.
Yeah. Well, I'm in it. I don't know if we could put anything late, but I'm done.
Okay. Thank you.
Thank you, Delegate. Delegate Bagnell, then Delegate Chisholm.
Thank you, Madam Chair, and thank you for this bill. We do recognize that this is a problem. In fact, xylazine has been on the rise in Maryland, and we've been watching it very carefully, working with the department. And I'm trying to figure out how we actuate this legislation, because as you may be aware, xylazine is actually a Schedule 3. So xylazine is scheduled, but to your point, medetomidine, and I'm going to have to practice that, is not scheduled, though it is, though they are both sedatives that are used by veterinarians. So my question is, you had mentioned that you were working with the department. They're reluctant or hesitant to consider scheduling at this time. Have you talked to the retailers? Do we know if having legislation that goes after the retailers, if the purchaser doesn't provide proof of purchaser's intent, do we know that is the point where these tranquilizers are coming into?
Sure. Yeah. No, I mean, look, I wouldn't want to put any of the retailers in a predicament, but what's good, what's already known is that these substances have zero purpose for anything other than animal tranquilizers. There is no other use for these items. Like, that's indisputable, right? And so they're still allowed to provide and sell them to veterinarians. So there would just need to be proof of that. And you got to be 21 years old. And that's really the only two requirements of the bill. And so if you're selling it to some other individual that's not a vet, yeah, we do have an issue with that. And the reason is because people are dying. And so the good news is that they're not used for anything else other than veterinary purposes. And that's clear. And so I think administering this without unintended consequences would be easy. I think the AG is very interested. If you can see their letter of support in the bill, they've acknowledged the significant problem in this area. And I think we came up with a really creative thing where it's like, if there's somebody that does it, it's not a criminal penalty, it's a fine. And the fine goes right into the substance abuse fund that's administered through the comptroller's office to kind of help the issue. But I think this is the right step in the right direction. And I think we can do it without upsetting the apple cart. I think we can do it without upsetting the folks that use this for veterinary purposes and the retailers that may provide it to for veterinary purposes. We just want to get this out of the hands of the people that are mixing it in with heroin and fentanyl. And it's just shocking how much of that is going on. It just really is. That's why we put the bill in. We just were amazed that we're the only state that's not doing anything about it.
And I appreciate that. I think we're very much aligned in that desire of getting it out of the market.
Thank you.
Okay. Thank you. Delegate Chisholm.
Madam Chair, and I'm going to follow up on Delegate Bagnell's question, because it does seem like I'm trying to figure out, I'm baffled on how it's being distributed. It wasn't seen in our illicit drug supply until 2022. Now it's being seen in Missouri, Colorado, Maryland, Pennsylvania, and California. It begs the question, if veterinarians are the only ones handling it, obviously somebody else is getting their hands on it, because I'd like to think most of our veterinarians are doing what they're supposed to be doing and administering to animals. Is there any idea or in your research on how it's getting out into the street?
Well, I hate to say it, so I'm not a drug dealer, right? There's only, but sure, it's on the record. You know, my best answer is that it's legal, right? So it's like, you know, people, illegal stuff manages to somehow slip through the cracks, right? But this is legal. You know, there's nothing that would prohibit a vet from, you know what I'm saying? I mean, it's legal. And that's the issue, is that there's probably a million different ways to get it out on the street legally, I guess. And what we're hoping to do is at least do something, you know, take a step in the right direction. I don't know all the supply chains of how they would get it, where they're getting it. You know, like if we tracing back, if we find an overdose victim and then a dealer, are we saying, hey, where'd you get this stuff? Did you get it from your local vet in Frederick? You know, like, where'd you get it? But I think this would put a lot of folks on notice, you know, and I think if there was a veterinary business, and again, I'm sure they're operating all in good faith, but if there was a business, they'd probably tighten up, because they're like, well, now, you know, the lawmakers are looking at it. We want to make sure that this stuff is where it's supposed to be, not anywhere else.
I think it might be an effort that's coupled with the federal government, because from what I can tell, it's only made in China and India. We don't manufacture it here. Yeah. So if we can cut off the supply, sure, and make sure it's only going to where it's. Thank you, Madam Chair.
Thank you.
Seeing no further questions, thank you, Delegate Pippy.
Thank you very much. Appreciate you.
I do have a question. Have you talked with the Attorney General's office? I know they're in support. They're recommending an earlier date, a start date. Do they have the capacity to set up that fast?
I think so, and obviously we're open to what the committee wants to do. If you guys want to make an emergency bill or adjust the bill in a way that can help them ramp up, you know, we're certainly open to that.
Okay, great. Thank you very much. Have a great afternoon. And that concludes the hearing on House Bill 1109, and we will now go to House Bill 1053, Delegate Buckle, Developmental Disabilities Administration, Self-Directed Services, Parent Providers.
Thank you,
And
Madam Vice
Delegate
Chair. Can Ms. DeLauder, she signed up to testify. Can she come up and testify? This is kind of a bill that she knows quite a bit about.
She did sign up, right?
Yes, she
Yes,
did.
I've got her. Are there folks you want on your panel?
The only one that I'm aware of that I know is here, I don't know if former Delegate Resnick is still here. I know Ms. DeLauder, and I'm sure some other folks signed up. But this is fine just for me.
Okay, all right, we'll go with that, and I've got some other folks who will come up and speak in favor after that.
Great, thank you very much. Thank you, Madam Vice Chair, members of the committee. Delegate Jason Buckle with House Bill 1053. I think everyone, one of the most interesting things I found in this session that we're now in week 8 or 9 is the broad bipartisan consensus that we must do more for our developmentally disabled community. We cannot endure significant cuts to the services that they receive, and that they are, if not the top of the line, they are basically the top of the line for our safety net programs and the ways that we should be spending money and directing resources here in the state of Maryland. House Bill 1053 comes as a result of the tremendous confusion and difficulty that sometimes parents and families have in navigating the DDA system and accessing benefits that are available to them. You'll hear the testimony from Mrs. DeLauder, who's here with me, a constituent of mine in Allegheny County, and the difficulties and the confusion that she experienced in finding out whether or not she could even obtain some level of financial support through a self-directed service program or other program to participate in the daily caregiving for her severely autistic, nonverbal young child. And she can tell you more than what I ever could about how that affects her life and impedes her ability to work and creates such an incredible strain financially upon her family and the great love that she has for that child. When we filed the bill, it was a result of this lack of clarity from individuals with the Developmental Disabilities Administration and the various bureaucracies in advising individuals as to whether parents in and of themselves were able to receive payment under the various programs that exist for caregivers. And there was some confusion that you could get money from our system for a third party to assist in caring for your severely developmentally disabled child, but that if you as a parent were in the best position to do that, you would not receive any of those funds, which didn't make a lot of sense. We filed the bill, and after filing the bill, we got some information from the department reaching back out to Ms. DeLauder and to myself that, well, yeah, family members can get it, and we think parent definitely should be included within that. And you'll see that in the notes that we can pass the bill that clarifies and signifies that parents are eligible for these supports and services. But even though you might be eligible, you're probably not going to get any of it because you're so low down on the priority list that you're going to go on a waiver list and it's going to be years and years and years and years. And I'm here to tell you that shouldn't work. We need to make a priority, and I trust the members of this committee who deal with these issues on a daily basis to continue to work towards finding a way to provide developmental disability supports and services to families who need it. That's what the bill is intended to do. It's really clarifying in nature, and you can see the department's remarks and the remarks from the Maryland Legislative Coalition and others. I don't think anyone is in opposition to the bill that simply clarifies, includes the word parent in the definition so that folks like Ms. DeLauder and others in the future, they don't ever have to worry. They don't have to call and get inconsistent answers. They can look right to the law and see that they're eligible for the services. And then the bigger problem, and I've spoken about this with the chair of the committee, the bigger problem is down the line, how do we get these services provided more to these parents of these children so that they don't get excluded from the funds? And with that, Madam Chair, I'd certainly love to hear Ms. DeLauder and her husband traveled here today from Allegheny County. They'd love to have the opportunity to tell you a little bit about their situation.
Absolutely. Please, go ahead.
Madam Chair, members of the committee, my name is Jennifer DeLauder. I am here to testify on HB 1053. My son, Loxon, who is 5 years old, was diagnosed with level 3 autism at the age of 2. He is also nonverbal. With his level of autism, he requires 24/7 care. Since his diagnosis, we have encountered financial hardships. He currently receives 30 hours a week of ABA therapy, which requires me to be present. This alone has caused me to step away from my full-time employment. We now have less income, but still enduring the expenses that come with his disability. I reached out to the DDA and I was advised that because my child is still young and it's already expected for me to care for him, it would not be likely for me and my family to qualify for any type of support, which is why I'm here today. I'd like to share some expenses with you. He has specialized safety clothing, $35 to $40 each. His GPS tracker, so if he does elope, we can find him easily. That's $600 a year. Safety, security, and communication equipment, medical grade car seat and stroller was $13,000. Monthly food supplements, travel, and extraordinary medical expenses. Some of these items require replacement as he outgrows them. They also exceed the needs of a 5-year-old without level 3 autism. Research shows that children who receive intensive early support are more likely to develop the skills they need to become more independent, reducing the long-term cost on state-funded services. So with that, I ask you to stand with us and advocate for families of all ages in this important program. Thank you.
Thank you. Thank you for sharing your story. It's really important to us, and for coming all the way from Allegheny County. I haven't seen outside, but I understand it's pretty rainy, so thank you for that. Questions for the sponsor or his witness? Delegate Morgan.
Thank you, Madam Chair. I just wanted to, you or your witness, Ms. DeLauder, just elaborate a little bit on the bill, because it's saying that you're providing for services. I mean, the bill clarifies that a parent of a recipient of self-directed service must have an option to provide. What is it exactly clarifying again?
So I think, thank you for the question, Delegate. I think what's clarifying again is when Ms. DeLauder originally reached out to the Developmental Disabilities Administration and indicated, I have this child. The child should be eligible for services and support and things of that nature. And part of what DDA does, as you certainly understand, is sometimes they provide caregivers so that the parents can go to work, because parents have to do that sometimes in order to provide for these families. What Ms. DeLauder, I believe, experienced was that because of the severe nature of her child's developmental disability, third-party caregivers just weren't very appropriate. And we don't live in, the most metropolitan area of the state. We don't have a wide panoply of selection of potential caregivers. The caregivers that her family experienced, while well-meaning and good faith, they just couldn't provide the services that Loxon needed. The interactions didn't work. They work with her. They work with his father, who's sitting behind us. They work with family members. And when she contacted DDA about, hey, do I qualify for any things, the original responses were, I don't think you qualify. We do it for third parties, not a parent. After we filed the bill, then it became a situation where the reach out was, oh, yeah, family members can get the services. They can get the support. We can basically pay you a small stipend. We can do what we would do for a third-party provider. But you're not going to get them anyway, because as Ms. DeLauder indicated, your child is so young, we just kind of expect you to take care of them. Well, everybody's expected to take care of their young children. But as you've heard, taking care of Loxon is very, very different than taking care of my 8-year-old son. He can't go to school normally. He can't be left alone with child caregivers. He has enormous costs. And essentially, Ms. DeLauder can't work. She was a real estate agent. She didn't say that. But she's essentially is in a position where providing care to her child is her number one. It's her only priority. And I think, as she said, that we're better off as a state helping people do that reasonably, not breaking the bank, not huge salaries, not anything. She's not looking for anything like that, but helping people do that may save us money long term. Because otherwise, unfortunately, children like Loxon are going to have a lifetime of these costs and supports and services that we passed on to Medicaid and other types of programs down the road.
Real quick follow-up. Ms. DeLauder, how old is your son?
He's 5 now.
He's 5. Well, thank you for coming down and testifying.
Thank you. Can I touch base on what you said? And this is the easiest way that I can put it to anyone, especially when I was told that my child is young. So I'm just expected to take care of him. We're not going to be put on any type of wait list. We're not going to qualify for services. With, diving into this, you're hit with this diagnosis, and it's a lot. So you start researching, you're flipping over every rock that you can find to figure out how you're going to best help your child. And so I've learned a lot, I've taken in a lot. And saying that you can't receive a service that can help your family because your child is young, But if they were more of a self-sufficient age, let's say 10 to 12, we'll put you on the list. And the easiest way that I can explain this to you is we don't put our children in school and expect them to just start learning at 11th and 12th grade. We want them to learn, we put them in school in those early developmental years because that's when they're taking everything in. So I feel like whether it's true or not, or I just talked to the wrong person at the DDA or their guidelines, if they're messed up or not, that's why I'm here, because I want to make sure that families of all ages have the same priority. Like if he has the same needs as a 13-year-old, they get it, but we don't because he's young and I'm just supposed to take care of him. That doesn't seem fair for my child and my family.
Well, thank you for providing more detail. Appreciate it.
Thank you.
Thank you, Madam Chair.
Thank you, Delegate. I have Delegate Kaiser, Delegate Bagnall, and Delegate Chisholm. Delegate Kaiser?
Thank you, Madam Chair. Delegate Buckle, I don't know if you saw the letter from the Maryland Department of Health.
Yes.
Where they said that relatives are already covered and that parents are part of that definition of relative. So I missed, what was missing? How is your bill, if passed, going to change anything?
So I don't know that it is other than this. I know that when Mr. Lauder contacted the individuals who worked for the Developmental Disabilities Administration, that's not what she was told initially. After we began the inquiry and filed the bill, then it was pointed to that statute. It said, well, it can include family members, and family members can include parents. And I have the letter right in front of me. Basically what the Department of Health is saying, and my point in the bill today, it's a think piece for how we can also address these issues, but in a very concrete way in the bill. Someone like Mr. Lauder or someone anywhere, rather than sort of relying on what someone tells you on the phone, they could now go directly to the statute and says, no, it says right there, parent is eligible for the services. I'm a parent. Don't tell me that I'm not. It's a very simple little bill, and I agree with you. I don't think that it will change, and the department says it won't change their policies directly. That's something we'll have to work on in the future about addressing the issues for younger children and getting them in. But I think this might remove, even for one person, two people, three people, that get that bureaucratic disconnect of I'm not eligible because the bill doesn't specifically, or the statute doesn't specifically say parent, and I can't just read it and figure it out on my own. That's really the purpose.
Okay, thank you.
Thank you.
Delegate Bagnall?
Thank you, Madam Chair, and thank you for this bill, and I think I'm probably going to provide an answer in the form of a question. Am I understanding this correctly? Am I understanding this correctly? That essentially the bill is codifying, it's clarifying that medically indicated, clinically appropriate, within the regulations of the existing waivers, that parents have equal standing, no more, no less, than any other support as an appropriate provider.
I think that's exactly correct.
Isn't that so?
I think that's exactly correct. Is that parents would get treated the same way as a third-party provider. If they're providing these services that would otherwise be covered and they fit within the block, they can be compensated in similar ways.
Thank you very much.
Thank you.
Delegate Chisholm?
Thank you, Madam Chair. I'm going to just follow up on what Delegate Bagnall. This is a technical cleanup bill, is all it is, to make sure that we define that a parent is also a caregiver when it comes to self-directed services. Yep. Hopefully this will quash any problems going forward for a parent that has to run in the same issue, because we have somebody that obviously read into this self-directed services too much and said, well, a parent doesn't qualify, because the parent does qualify, but hopefully this will put that to bed.
That's correct. It's very simple and clarifying to enable that there won't be any confusion about it going forward, and then we can work on the broader problems of how to get people better qualified and how to use those dollars most effectively.
Okay, great, thank you. Delegate Woods?
Thank you, Madam Chair. And so to follow up with Delegate Bagnall and Delegate Chisholm, mine is also a statement in the form of a question. The reality is that despite not having the clinical knowledge, that the parent knows the most about that child, and so should certainly be considered when you look at people who are being provided the support necessary to meet the needs of the child. Isn't that so?
That's exactly correct, Delegate. Exactly correct. Makes common sense.
Okay.
Thank you.
Thank you. Seeing no other questions, thank you very much, Delegate and Mr. Lauder, for being here today.
Thank you, Madam Vice Chair.
I've got a few other folks who like this bill. Cody Stevens, Kirill Resnick, Sherry Dexter, Michelle Gregory, and Adam Wyndham. Well, Adam, let's wait on you, because you've got an amendment. Okay. Mr. Resnick, so good to see you. Why don't you get started?
Right. Thank you, Madam Vice Chair, members of HGO. I am here in support of HB 1053. Again, my name is Kirill Resnick, and I am here on behalf of the Concerned Citizens for Self-Direction, a participant and family advocacy group supporting self-direction for Marylanders with intellectual and developmental disabilities. As you've heard, this legislation is simple and codifies existing practice to allow a self-direction participant to choose a parent or legal guardian to provide services under the program. Though the law already authorizes a family member to serve in that capacity, experiences in dealing with the Developmental Disabilities Administration has demonstrated that this clarity is necessary. The members of CCSD look forward to continuing to work with the DDA and believe that this clarification in law will only further that relationship. I will now turn it over to some of the other members of CCSD, and I urge the committee for a favorable vote. Thank you.
Thank you. Who would like to go next? Just pull it close.
Can you hold this up for me first? Thanks. Thank you. Good afternoon, Vice Chair, members of the committee. Thank you so much for having me here today. I'm holding up a picture of my son, Timmy. He would have been here today along with our family as staff, but he actually was at Montgomery College at the Challenge program today, enjoying his day with family out in the community. I'm here today, as Kirill said, on behalf of the Concerned Citizens of Self-Direction Maryland. I am in support of House Bill 1053. What I'd like to talk to you about today is that my family has fought for Timmy, who's got severe cerebral palsy. At every turn, whether that's legal, education, medical, we've had to navigate systems through countless meetings, traveling thousands of miles sometimes for care, and justifying things over and over and over, including why he needs the same services that he's been required to have since birth. Through every milestone, every school event, and even an emergency medical flight where I had to be on a medevac helicopter, praying he wouldn't die on the way to the hospital, we've been there. Not because it was just Timmy with special needs. We would have done the same for our two daughters, because our children are our priority. But here's the truth. Nobody provides better care than the families. The American Academy of Pediatrics states that children with disabilities receive the best care from those who know them best. We're there 24/7, 365, ensuring that Timmy's days are filled with dignity, respect, and hopefully lots of laughter. Yet, there are some that criticize families like mine who want to be paid for work that's done selflessly for years. We are there to support our children. We provide the best care. And I just hope that you will do your best to continue to support the bill that is out there. We are not walking away, and we hope you won't either. So thank you so much for the time today.
Thank you for sharing your story, but would you tell us your name, please?
Sure, I'm so sorry. Sherry Dexter.
Thank you. Okay, next, please.
Honorable delegates, thank you very much for having us today. My name is Michelle Gregory, and I have the honor of serving as a council member for District 4 in the city of Salisbury on the Eastern Shore. But today I'm here as a mother, a caregiver, and an advocate. My eldest son, Nick, is profoundly disabled. For years, we searched for answers, and it wasn't until he turned 18 that we finally received a diagnosis, Lennox-Gastaut syndrome, a severe and treatment-resistant form of epilepsy that shapes every part of his life. When Nick aged out of school, we feared for his future. A brief attempt at a day program led to more seizures, hospitalizations, and constant staff turnover. The system failed him. But in 2017, we found a solution, a program that allowed me to become his paid caregiver. The impact was life-changing. His seizures dropped dramatically, hospital visits became rare, and after years of denials, my husband was finally approved as a caregiver too. Today, Nick has 2 dedicated caregivers, his own parents, working 80 paid hours a week, but in reality, his care is 24/7, 168 hours a week if you're counting. This program isn't just about financial support, it's about stability, dignity, and keeping him in the community he belongs to. Without it, families like mine face an impossible choice: watching our loved ones struggle or placing them in institutional care at a far greater cost to the state and a devastating cost to their quality of life. By passing House Bill 1053, you're not just ensuring parents can be caregivers, you're protecting a vulnerable population, ensuring disabled individuals receive the care they need, and keeping them where they thrive at home. Thank you.
Thank you. Go ahead, sir.
Hello, my name is Cody Stevens. I live in Dorchester County, representing over 100 families on the Eastern Shore, several of which are directly connected to this bill. My 9-year-old son has a severe disorder called polymicrogyria, which heavily affects his speech, motor function, cognition, emotional difficulties, severe seizures, and have led to 2 brain surgeries. Our lives have been far from steady, filled with travel to therapies, doctor visits, emergencies, and more. But it's only possible because we're able to stay by his side. Echoing others, we're saying that we typically work a 40-hour work week, but for us, it's 168 hours a week because it's 24/7. Yet we only ask for the 40 hours in support and help to manage this responsibility. Holding a full-time job with a traditional boss has become unrealistic because you often hear things like, be here at 4, consider your termination. A sentiment echoed by families like ours who are forced to choose between our work and our loved ones. This is not expected to change in my son's lifetime. There are also significant behavioral challenges for my son that require him to be within arm's reach, as he is an elopement risk and a potential threat of physical behavior, to which we have to address directly and properly. To train someone in the ways of our son would be a tall order. There are triggers, body language signals, and other nuances that cannot be taught without spending significant time with him. My wife and I are both well versed in these nuances and can redirect and eliminate an episode before they become a significant problem needing further intervention. The statement "parent knows best" rings loud and clear here. Then there's the issue of the pay deductions that were recently threatened to start April 1st. To take away the opportunity to assist our own child would mean we would be forced to train someone else in these untrainable things while subjecting them to the potential emotional and physical episodes for not much over minimum wage. We have recently seen that our local Dunkin' Donuts on the Eastern Shore is hiring for $20 an hour. Due to the conditions, I wouldn't blame them for turning down a job in exchange for selling donuts. This is ignoring the fact that my son will not positively react to new strangers, new faces, and other people's ways of handling situations. We work diligently to put a system into place that works for our child. Families all over the state have done the same, with each case being different, but it's the parents' consistency and parental wisdom that makes this system possible. We have fought hard to make sure our child has a safe environment, surrounded and equipped with the materials that he needs to live his best life with dignity. Asking us to reinvent the wheel regarding our child's care would have more than negative consequences. It would put the family situation into negativity and regression, a situation only truly understood by the families that have lived there before. Thank you.
Thank you. I have one more favorable witness. That's Sherry Bailey. Would you go ahead, Ms. Bailey, please?
Yes, thank you. Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. My name is Sherry Bailey, and I wholeheartedly endorse this bill. As also another parent of a child with special needs, I have also faced significant challenges in finding appropriate care for her. My daughter Layla is nonverbal, has epilepsy, limited mobility, is not potty trained, even though she's way beyond that age, has a platelet dysfunction, is fed by feeding machine, among other obstacles. I share this information with you not to elicit any sympathy, but to highlight that Layla, like many others in our community, has unique syndromes, some of which, such like hers, are very rare. Layla was actually the first documented case of Jacobson syndrome by Hopkins in 2014. They have also indicated to me that they're learning about this syndrome through me. So this really underscores the necessity of allowing parents, family members, and legal guardians to provide self-directed services under the DDA program. As was just stated, no one knows our babies and our children and our adult children more than us. Families like ours have pursued numerous avenues to secure care. Me personally, over the last 10 years of Layla's life, I have had a very difficult time. I've even had to seek au pairs overseas to come into my home and be live-in nannies just because I had no other option. I've had child care facilities and care facilities actually deny Layla, claiming that she is a liability based on her complexities. As a working mom and an executive of a Fortune 500 organization, that leaves me with very little opportunities to find decent care, qualified care for Layla. This approach of trying to find other avenues is not just costly for families, but also limits growth in our economic growth in our communities. I strongly urge you to support the advancement of this bill to ensure continuity of care, choice, and flexibility for our families. Thank you for your time.
Thank you, and I want to thank all of the families here today. It really helps us to understand the situation in ways that we couldn't otherwise if we haven't experienced it. So thank you so much. Are there questions of these witnesses? I think you answered a lot of questions for us. Thank you all for your time and your testimony today. I have now Mr. Adam Wyndham, who has favorable with amendment. Welcome back to the table, Mr. Wyndham.
Thank you. Running back and forth today. Good afternoon, Chair and members of the committee. My name is Adam Wyndham, and I'm here today as a parent advocate and full-time caregiver for my child with severe disabilities. Jennifer's story that she told you a little while ago was my story 7 years ago, being run around in circles with state offices and being told inaccurate information. The Self-Direction Act currently allows an, quote, option for family of staff. But as we saw attempted back in November with the new policy changes, the DDA has massive leeway in placing so many burdens on this option that they can make that option unattainable. HB 1053 does further clarify that family does include parents, which is important. I urge you to protect and strengthen the right of family members to serve as paid caregivers by also adopting a friendly amendment I'd like to propose for this bill. Everything the DDA has done over the past year suggests an effort to make family of staff option so difficult that family members are forced out of it. Families already stretched thin must jump through excessive bureaucratic hoops, complete unnecessary paperwork, and repeatedly prove what should be obvious, that we are the most qualified. Without this option, families would be plagued by workforce shortages and high turnover, leaving vulnerable individuals without consistent specialized care. Many of us cannot work traditional jobs because caregiving is a full-time 24/7 commitment. The following amendment is what I'm proposing is to remove and protect unnecessary and discriminatory administrative burdens placed on family caregivers currently by the DDA. I'd like to propose that the bill be amended to state that the administration shall not impose additional burdens on family caregivers beyond what is required of non-family staff, except for the hiring of a support broker. No additional requirements to prove other qualified staff are unavailable, no designated representative requirements for family caregivers, no excessive paperwork or hurdles designed to discourage family caregivers. And also that the administration shall not subject living caregivers to the electronic visit verification requirements. This was actually stated in 2019 by CMS that living caregivers are not subjected to EVV requirements, yet Maryland chose to mandate it and put in a complex process to become exempt from it. I urge this committee to adopt this friendly amendment to HB 1053 and ensure that families are protected from unnecessary barriers and support caregivers who are already doing the work. Because when families can care, individuals with disabilities can thrive. Thank you.
Thank you very much. Questions for this witness? Delegate Kipke.
Thank you, Madam Chairman. Adam, I just want to thank you for your advocacy. You're a former constituent, and I want to apologize to you on behalf of the state for what they've been putting you and so many through lately. You know, we very much care, and I know it's hard for you to find the time to do what you're doing, but you're doing great work for so many people. And so I just want to say thank you.
Thank you, sir.
Thank you, Delegate. Seeing no further questions, thank you very much for being here and for your advocacy. That concludes the hearing on House Bill 1053, and we will go to House Bill 1066. Delegates Ruth and Gazzoni, Commission on Behavioral Health Care, Treatment, and Access, Membership, and Work Groups. Welcome back, Delegate Ruth.
Madam Chair, members of the Health and Government Operations Committee, I am pleased to be before you again. I have been here a lot this session, I believe, but I'm always happy to come here. I'm here today, for the record, I'm Delegate Sheila Ruth. I'm here today presenting House Bill 1066, Commission on Behavioral Healthcare Treatment and Access Membership and Work Groups. So what we seek to do is to look at substance use and improve the health, social, and economic outcomes by taking a look across the spectrum from harm reduction to treatment to recovery services, housing, and criminal justice system involvement, and really try to identify the best outcomes and how we can achieve those. It does this by adding on to the Maryland Commission on Behavioral Healthcare Treatment and Access. First of all, it adds 8 new members added to the commission to include more holistic viewpoints. It would be a representative of a harm reduction services provider, an expert in drug policy reform, an individual with expertise providing housing services for those who are in recovery, and one in providing healthcare services to those experiencing homelessness, as well as some individuals with lived experience. The second thing it does is it adds a 5th work group to the commission, specifically charged with looking at the improvement of health, social, and economic outcomes relating to substance abuse, including questions such as how many individuals are directed to services by the criminal justice system, the health outcomes of individuals who have received services mandated or directed through the criminal justice system versus those who sought them voluntarily, including a review of current research on the efficacy of voluntary versus criminal justice system mandated treatment, the impact of current criminal justice involvement related to substance use on the health and well-being of individuals, their families, and their communities, the fiscal impact to the state and local governments resulting from current criminal justice involvement relating to substance use, the equity of criminal justice involvement, and availability and accessibility of data on the above issues. Now, we fully recognize that substance use falls under the umbrella of behavioral health, and it was always intended to be looked at as a part of this commission. However, if you read through the testimony that's been submitted, I think you'll see broad agreement throughout the community that there's a feeling that substance use needs a specific focus, that while the commission is doing great work on behavioral health generally, there really needs to be a specific look at substance use and at those outcomes. And so that I urge you to look at the written testimony, including from MedChi, Behavioral Health System Baltimore, and the Maryland, D.C. Society of Addiction Medicine, as well as others who support this bill. And, you know, so I want to, first of all, address the fiscal note. It's not zero, which is not good, but it's $38,000, which is less than the $75,000 I believe that needs approval. And I also wanted to mention that we had initially started with a bill that would have created a whole separate task force. And we received advice to try to roll it into the commission. If this had been a separate task force, the fiscal note would have been much larger than $38,000. So we are actually saving money by doing that. I also wanted to address the Maryland Department of Health letter of concern. I want to thank Sarah K. Saran for reaching out to me, sharing the letter, and for meeting with me. We had a great meeting, discussed a lot of things. MDH's primary concern is adding weight to the commission, which adds to the burden. And they feel that the things that we're looking for are already covered. And so I did want to just mention that I think that and you know, again, I appreciate Sarah K. Saran. I appreciate all the work that MDH is doing for the commission, and she also sent me work that MDH is doing specifically with substance use. But so no offense to MDH, but I think if you look at, they include 6 I think it's 6 out of the 14 things for the group that they feel overlap with what we're asking for. And if you look at those, I think that really highlights why this work group is needed, because all of these are related more generally to behavioral health, and none of them really get at the information we're trying to find out. For example, one of the things that it talks about is the criminal justice system work group, and there is a criminal justice system work group, but I believe they're looking at treatment through the criminal justice system and how to address that, whereas we really want to look at data and look at outcomes to really look at this question of that is constantly comes up, whether it's better outcomes to meet people where they are and to refer them to voluntary treatment, or whether it is to mandate treatment or divert them through the criminal justice system. Which one is going to have better outcomes generally? The equity of that as well. And you'll see in some of the letters that there is some data about different outcomes from criminal justice treatment for Black people and Latino people versus white people as well. So, we really think that this is needed and will be helpful to have a specific focus on substance use. I ask for a favorable report. Thank you.
Mr. Higdon?
Thank you, Madam Vice Chair, members of the House Government Operations Committee. My name is Thomas Higdon. I am the Executive Director of the Maryland Alliance for Sensible Drug Policy. We are a new advocacy group led by people with lived or living experience with substance use. And I'm testifying here in support of HB 1066, but my testimony really draws on my lived experience. I used illicit substances for more than 2 decades, and during that time, I completed many treatment programs. Some of them I found on my own or through my healthcare providers. Others I was, shall we say, introduced to by the criminal justice system. Regardless of how I got there, I was always motivated. I wanted help, but my experience was vastly different depending on how I got to the treatment program. The court-referred programs tended to be understaffed and underfunded. Their staff was often poorly trained and poorly supervised. But beyond the quality of care issue, there was a more fundamental difference between these two ways of reaching treatment. It was how I was treated. In the programs that I sought out or that I reached with my healthcare providers, I was a human being, a partner in my own treatment. I was asked what I hoped to accomplish during treatment and how the program could support me in reaching my goals. I left feeling energized and empowered. The court-referred programs, I was a criminal. I was a passive participant who was to be monitored for compliance. Upon arrival, I was given cookie-cutter treatment plans, a book of program rules, and a reminder that if I broke any of the rules, I would be out on the street by evening and in jail by morning. I ask you, which approach sounds like it's going to be more effective? Which is going to have better outcomes? Given the number of people involved and the millions of dollars involved, I think the least we could do is study these issues, and that's what this work group would do. So I urge you, the committee, to give a favorable report to the bill. Thank you.
Thank you. Perfect timing. Questions? I think that's Delegate Ross.
Thank you so much. So I wanted to just ask about the overlap that you talked about. And so I wondered, really just 2 questions. So how do you know, just percentage-wise or just roughly, if you could just quantify how much of the work you're proposing for this work group is already facilitated within the commission? And you may not have the numbers, but just most, some, a little bit, just to give us an idea of how much of this is already done within that group.
I can try, sure. So I'll take that question. I don't think that we can give you a clear breakdown. I have been following the commission's work, and I've read all of the published materials that they have. I actually at one point was going to I thought it would be interesting to give you like the number of times the word substance use shows up in their reports, and it was actually not many. But I will tell you this, is that the commission is charged with studying behavioral health services here in Maryland. And I'm sure the commission, this committee is familiar with the DSM, which is the Bible for mental health and behavioral health disorders. There are 300 different disorders in the DSM, only 12 of which applied to involve substance use. So that's a huge piece that this commission is supposed to be looking at, and substance use is only 12. But here are the numbers for Maryland. 1 million Marylanders have a mental health disorder. Of that, 800,000 people have a substance use related disorder. So substance use is disproportionately represented in the body that this commission is charged with looking at. And let's not overlook the fact that 1,500 of those people died last year from overdoses. So we feel that given the scope of the problem, given how large the problem of substance use disorder is within the behavioral health system, and given the number of deaths that are involved, that it deserves a special work group to do a deep dive into these issues. Because frankly, we're worried that it's just going to get lost in the mix because it's such a big universe. And that's why we think it deserves a special work group. And I also would add that, and correct me if I'm wrong, members of the committee, but when this commission was created, there was discussion that we might need additional work groups. And that was sort of baked into the system, that somewhere down the road, we might need to add a work group if it looked like we needed to do a really deep dive into one particular area. And so that's all we're doing here, is saying that we're worried that substance use disorder is getting lost in the mix, and it deserves its own work group.
Okay, thank you.
Okay, thank you. Delegate Kaiser, I'm going in the order that I saw the lights. Delegate Kaiser.
Thank you, Madam Chair. My question, Delegate Ruth, I am flabbergasted that this commission already has 41 members, which is large, unwieldy, and any other time I've paid attention, I've been told, cut them down, cut them down, cut them down, and here you are adding 7. I understand that you're looking to cover an area that's not seemingly covered now, but do you have any concern? Is this work group doing good things now? Do they have the capacity to take in 7 new members? Maybe I need to talk to someone who's on that work group. It is already too big, I guess, if you could address that.
Thank you for the question, Delegate. And yes, it is big, and I know that large work groups can be unwieldy to work with, and I believe that was a part of MDH's concern as well. We did feel that these members that were representative of points of view that are not currently on the commission. So, I'm certainly open to whatever changes the committee would want to make. But, one possibility, and it's not done with the other work groups, but maybe to have these members added specifically to that work group, but not be a part of the larger commission, where that work group could then have representatives from the larger commission who would report back. That's just something that off the top of my head might be something that worked. But I'm certainly open to whatever we can do to make this work. Thank you.
Delegate Kaiser, I'm on the commission. And the way that it's organized, I'm not sure how I got on it, but the way that it's organized is a set of work groups that are working relatively independently and then presenting to the large groups. So you don't have the dynamic where there's 41 people sitting on Zoom all talking at once and over each other. It is reports from each of the work groups and then, consideration of some follow-up. So I think, from my perspective, there's probably the capacity to do that, to add that extra work group and those people in order to focus on this because of the way the commission is organized. And it's been, it does a lot of work. We're studying a lot. So I'm going to go to Delegate Johnson.
Thank you, Madam Chair. Thank you, Delegate Root, for this bill. Also, I wanted to ask you, on the Department of Health's letter, they not only talk about duplicative function, but on the back they talk about staff. Each work group needs 2 to 3 staff to function properly. So are they saying they don't have the staff or that it's stretching them too thin? Can you tell us a little bit about that?
Thank you. I am aware that they have that concern about staffing, and that was sort of what I meant when I said the burden. I will note the fiscal note of $38,000. So I don't think they're saying even though their letter says that they need additional staff or they have all these staffers, I think that the fiscal note, so it says, the estimate reflects the cost of hiring one part-time 50% contractual health policy analyst. So they seem to be in and the fiscal note, obviously comes from the department as well. So they seem to be saying they don't need another full staffer, but maybe half a staffer.
Okay, thank you.
Thank you.
Madam Chair.
Okay. Delegate Bagnall.
Thank you, Madam Chair, and thank you for this bill and for actually working with me early on. Spoiler alert, it was my suggestion to add it as a work group.
We weren't going to call you out.
I appreciate that. I'll go ahead and own it. But I appreciate the fact that you're trying to look at the care continuum, because I think it is a challenge within the substance use community and the recovery community. Delegate Ruth, before you looked at turning this into a work group, and you are correct that the original bill did make room for additional work groups. That was how we managed the 17 favorable with amendments in the original hearing. How long was your original task force as you envisioned it? How long were they going to operate?
How long it was going to operate? I believe it was 2 years.
2 years. And I am correct that the Behavioral Health Commission is a 4-year commission currently in their second year, so they have 2 years remaining. Is that correct, Madam Vice Chair, who is also on it?
Sounds like it, Delegate. Thank you.
Thank you very much. And if I could have one follow-up. I saw the letter from the Department of Health. Have you been in conversations prior to ahead of this bill hearing, and what has the response been?
Yes, thank you for the question. I did meet with Sarah Case-Huron, and I can't remember who else I met with. I apologize. But we did have a good conversation. I also did ask them if they had concerns about the way this was structured being, too much of a burden, if they had amendments that would, make it less of a burden, if they could send those to me. I did explain that we didn't see it as being duplicative because the questions that they're looking at in behavioral health, while they are very important questions, they don't really get at some of what we're trying to find out. So Sarah did send me a list of the work, separate from the commission, the work that MDH is doing on substance use, which is substantial and great, and I really appreciate it. And I actually think the work that they are doing, some of which is collecting data, would actually assist this work group, because they are already doing some things that would help. But we still, in spite of that work that they're doing, we think there needs to be a structured look at substance use and really, analyzing the data and achieving these outcomes. Did that answer your question?
Great. Thank you, Delegate. Delegate Taveras.
Thank you. Mr. Higdon, right?
Yeah, it's Higdon, yes.
Higdon. Mm-hmm. If you could repeat a little bit of your experience for me. I just would like to know, when you said that when you were trying to recover and it was linked with the court system, you felt one kind of way, but when you did it, I wasn't able to hear. When you went to another venue, you were treated differently. Could you speak more on that experience?
Sure. And the reason that I brought up that specific experience is, one, our organization is about lifting up the lived experiences of people. We feel that it can benefit policymaking to hear that. But also that this bill, one of the things that the work group does is specifically examine the outcomes of treatment for people that seek it out through the community or who get to it through the criminal justice system. And given the numbers of people and the amount of money involved, we thought that's a pretty good thing that we should study. In my particular instance, as I mentioned, I used illicit substances for a very long time. And during that time, I reached out for help. I was probably in treatment more than a dozen times, if you count inpatient and outpatient. As you can imagine, the quality of care and even I'll be honest, even my commitment to any particular program varied widely over the years. But I did notice a very distinct trend. And in those times, I was also involved with the criminal justice system. I used crack cocaine, and you can't use that for very long without eventually finding yourself in handcuffs. I'm happy to say that today crack cocaine is not in my life, and I'm not in handcuffs, but there was a time. But I noticed that there was a very, so I would go to treatment, and when I arrived at treatment, especially if I had health insurance, but that's a different story, I was treated a certain way, and I was really treated with humanity. I was asked to be an active participant in my own treatment. I was given support and guidance, and when I left treatment, I felt empowered that I could do this. And I was connected to resources that helped support me in my recovery. When I was directed to treatment through the court system, whether it was a stipulation in my probation or whether it was simply part of the plea agreement, a more informal, when I arrived at the treatment program, I was now referred by the criminal justice system. And even if it was even if they had other clients there who were not, I was treated differently. I was treated like a criminal. I was treated as somebody that needed to be watched. It was more about my compliance with the program rules than whether I was actually getting the help that I needed. And so when I left those programs, I often felt demoralized. I felt disempowered. Ironically, being sent to treatment through the court system really, in a way, fueled my addiction and undermined my attempts at recovery. Now, I'm not saying that this is the experience of everyone. I'm giving you my personal experience. I do know many people that have had a similar experience, but I'm sure we could find somebody that would come up and say that the best thing that ever happened to them was going to prison for 20 years. I actually know people with that story. But I'm saying, given how negative my experience was, given how many people I know that have a similar experience, let's study it. Let's find out what the reality is. Let's get the data. And that's what that's one of the things this work group would do.
Okay, Delegate. All right, thank you very much. Seeing no other lights, thank you both very much for your time, your testimony, and bringing us this bill. It
Thank you.
concludes the hearing on House Bill 1066. And Delegate Howard, you've been waiting very patiently over there, so we're going to go to House Bill 1289. Delegate Howard, Drug and Alcohol Treatment Programs, Discharge of Patients, and Referral Services Standards.
Thank you. And in the interest of time, bring up my pen.
Yes, please do.
Okay. Good evening, colleagues. Good to see you all. For the record, Delegate Howard here, pleased to present HB 1289, asking for a favorable report for the Drug and Alcohol Treatment Program's Discharge of Patients and Referral Services Standards Bill. This bill requires the Maryland Department of Health to establish standards for discharge of patients from treatment programs, referral services offered to patients by treatment programs, and also establishes a December 1st, 2025 that MDH must submit a report to the governor and the General Assembly on the status of regulations to implement a plan for the enforcement of this legislation. Patients who elect to be discharged from homeless shelters to homeless shelters rather than recovery residents that choice will be reflected in their treatment plan and is absolutely what I had in mind when crafting this legislation. There is no lack of available transitional recovery housing. There's 600 recovery residents in Maryland right now. In Montgomery County in 2024, there was 2,300 people in homeless shelters. Of those, 166 came directly from substance use detoxes. And so what I'm seeking to do is, as folks are being discharged from a higher level of care, is to make sure that unless they choose, that they are not discharged directly to a homeless shelter. And with that, I'd like to turn it over to my panel.
Hi, Lisa Lowe. First, I'd like to make a comment regarding the substance use disorder community. We do not talk about the retail community to mean both the sellers of goods and services and the consumers of those goods and services. On the contrary, there's sellers and there's buyers, and we make laws like the Consumer Protection Act to protect consumers, and we make laws like copyrights and trademarks to protect business owners. Why then does it become so difficult to make this distinction when we talk about the goals of for-profit treatment providers and people who utilize these systems of care? We can't seem to differentiate between treatment providers and patients within the community. This is not a bill to benefit treatment providers. It is a bill to protect their patients. A mere 11 days ago, this committee unanimously voted a bill out of the House and over to the Senate calling for improvements in the oversight of SUD treatment programs. Delegate Rosenberg's HB 722 calls for revisions to COMAR 1063 to prevent events similar to those that occurred at PHA Healthcare, including patient relapse and death. Thank you for that bill, Delegate Rosenberg. HB 1289 calls upon the department to make similar clarifying revisions to COMAR. The consumer must have an expectation that they will be discharged safely to a facility that is conducive to their recovery. This isn't rocket scientist. 1, meet with the client. 2, unless they wish to be homeless, pick up the phone and locate a bed in Maryland's 600+ recovery residences. 3, fax over the treatment plan. In conclusion, I would just like to say, if you're upset about the treatment milieu at PHA Healthcare and you championed a bill that basically told the treatment industry that you were not willing to tolerate their very poor standards any longer, then why have you allowed this bill to linger in this committee for 9 years? PHA Healthcare is steps above a homeless shelter or a tent city on the streets of any city in Maryland. Thank you for a favorable response this year.
Madam Vice Chair, committee members, thank you. My name is Liz Kruger. I am the Director of Homeless Services for Interfaith Works. We are a nonprofit based in Montgomery County and serving Prince George's as well. And we work with individuals and families experiencing poverty and homelessness. We are in full support of House Bill 1289 because of the increasing challenges we are experiencing in our homeless shelters. We have 4 of them, and we are seeing an increased rate of discharge from substance abuse providers, and we are noticing that the individuals need specialized care, which we cannot provide. We don't have the specialized training for our staff or the accommodations that are necessary. Last year in 2024, about 7% of our shelter population have been discharged from treatment providers. And I don't have, that's about 84 people, by the way, and I don't have all the outcome data for our shelters, but at our biggest shelter, which is in Silver Spring, every single one of those individuals relapsed. And to me, that is a failure in our local healthcare system, that we are not properly considering the environment of a homeless shelter, which is no place for someone seeking safety and recovery. So what we so much like about this bill at Interfaith Works is we understand that many people will choose not to go to recovery residences or take other options, but it is we're insisting upon a standard of discharge planning that would require exploring, or we hope would require exploring the different options out there, as we often hear that our residents have not been offered any recovery residences and are often just discharging 2 to 3 days before discharge. So we are hoping that proper discharge planning can address this major deficit and gap in the healthcare. So thank you very much, and we urge a favorable report.
Thank you very much. Thank you all for your testimony. Questions for this panel, the sponsor in this panel? Seeing none, I think you pretty much covered it. So We have an unfavorable panel, Therese Hessler, and is Corey Riccotto in the, she is, would you bring her up, please?
Thank you.
Thank you. Hi, Ms. Hessler.
Hello, Madam Vice Chair. Thank you so much for having me. For the record, my name is Teresa Hessler, and I'm here today on behalf of the Recovery Housing and Treatment Center Coalition of Maryland, and we are in very respectful opposition to House Bill 1289. We truly appreciate the intention behind this bill and acknowledge the committee's work last year to address concerns regarding discharge procedures and drug and alcohol treatment programs. Ensuring safe and effective discharge planning is essential, and we share the commitment to high standards of care. However, House Bill 1289 is unnecessary and could have unintended consequences that hinder treatment access rather than to improve it. Maryland already has regulations in place through COMAR, and I've noted in my written testimony what those are and have listed them out, which do require individualized treatment planning, discharge criteria, and appropriate referrals. Treatment providers must document the reason for discharge, services provided, and recommendations for continuing care. House Bill 1289 does not introduce new substantive protections beyond what is already required. Additionally, the Department of Health and the Behavioral Health Administration are actively updating state regulations to align with the American Society of Addiction Medicine, or ASAM's, national standards. These updates are expected in spring or summer of 2025 and will provide a more comprehensive approach to updating cohesive efforts in this space. And for these reasons, we respectfully urge the committee to oppose House Bill 1289 and allow the ongoing regulatory updates to take effect before introducing additional legislation. Thank you so much for your time and consideration, and we welcome continued dialogue on how to best support Maryland's recovery community. Thank you.
Thank you. We're going to hear from Ms. Bricotto, and then we'll open for questions.
Hi, this is Corey Simkin-Bricotto.
Are you able to come on video or?
Oh, sure.
Okay. There we go.
Yeah, there you go.
Go
Hi.
ahead with your testimony.
Okay, thank you. Good evening. Thank you for the opportunity to provide testimony on House Bill 1289. On behalf of Elevate Recovery Centers, I present this testimony in strong opposition to this bill. Elevate Recovery Centers provides outpatient substance use and mental health services with locations in Glen Burnie and Silver Spring, Maryland. Our vision is to lead the way in facilitating and promoting excellent client service delivery, and that client service delivery includes proper discharge planning and placement. While we recognize the importance of ensuring appropriate discharge and referral standards in addiction treatment, this bill imposes rigid regulations that could have unintended negative consequences for patients, treatment providers, and the broader recovery ecosystem. House Bill 1289 mandates extensive and prescriptive discharge planning processes by way of language that is contradictory in nature and could be harmful to the provider and patient if this legislation is passed. On page 2 of the proposed bill, it states the discharge is prohibited if the patient will be homeless or reside in a homeless shelter upon discharge. While page 3 states if a patient is transitioning to a homeless shelter, and then paraphrasing here, that outpatient services must be in place prior to that transfer. The current process for discharging or transferring patients begins during the patient's intake assessment. Individuals are asked about their goals and plans for discharge. Our team utilizes referral sources, family members, etc., to develop an individualized discharge plan. And prior to that discharge, our team secures referrals to community agencies and resources for aftercare based on the needs identified during that assessment and weekly meetings. If a patient chooses to terminate treatment of their own volition, referrals are offered, including alternative care, housing, and support group contacts. Many of the required referral services, such as guaranteed placements in recovery residences, or halfway houses are beyond the control of treatment centers due to limited statewide resources. The inability to comply with these mandates could result in unnecessary delays or legal liability for facilities operating in good faith. COMAR 1047 provided discharge guidelines not found in current regulations under COMAR 1063. However, I do recognize there are sections of the drafted COMAR revisions, which will be presented formally in the spring or summer, that address how to handle discharges appropriately, but only for select provider types and levels of care. It may be advantageous to use this existing material as a foundation for discharge guidelines for all levels of care and add guidelines for safe and appropriate discharging, both planned and unplanned. This would provide a solution for both the patient and the provider to ensure the patient's autonomy in their discharge planning while ensuring providers follow a set of guidelines for appropriate discharge planning, which can be done by way of regulation, not legislation. This bill prohibits discharges in cases where a patient may be homeless, but it does not provide additional funding or resources to address the lack of available transitional housing. Treatment centers are not equipped to house patients indefinitely, and without corresponding investment in recovery housing, this requirement seems impractical and unsustainable. Thank you. Thank you for your time.
Thank you. Thank you for that information. Let me open it for questions for these witnesses. Seeing none, thank you very much. Thank you for your, oh, who did I miss? Oh, go on. Delegate Tavares. This is the first time today, I think.
I'll forgive you.
Thank you.
Thank you, Madam Chair. So, Ms. Hessler, you highlighted in your testimony that your client believes that HB 1289 is unnecessary, duplicative, and misaligned with the national best practices in addiction treatment. Can you speak more to that so that we could kind of get a better grounding as to why they believe that?
Thank you so much, Delegate. And if it is okay, I may see if Ms. Shade would like to answer that question, since she is one of our providers and a member of the coalition and could better speak to exactly what standards they adhere to.
Did you hear the question?
Sure, I'm happy to help with this question.
Okay.
So while I don't have the, I do not have the ACM criteria in front of me to speak it, to state it directly, but it's in line with some of what I was in my testimony also in terms of the discharge planning being individualized, the patients having that autonomy, and allowing them, throughout the entire process to make those, those decisions.
Okay, Delegate, is that good? All right, let me look around again, make sure I don't miss anybody. I don't see anyone. Thank you both very much for your time, your testimony, your patience and endurance today. I appreciate it.
Thank you.
That concludes the hearing on House Bill 1289, and we're going to go to House Bill 1136, Delegate Rosenberg, Community-Based Residential Facilities, Licensing Entities, Provision of Licensing Criteria, and Single Point of Contact. Delegate Rosenberg, and I believe, Matt, you are up now, and I apologize that you had to wait this long.
I'm unfavorable.
Oh, I'm sorry. I have the, never mind. Delegate Rosenberg.
Yeah. Madam Chair and members of the Health and Government Operations Committee, this afternoon we've heard from people and their parents whose care should be provided in the community, not in some hospital or penitentiary-like facility. That for decades now we have our policy is to provide for community care and not the other kind. But we all know that these groups are not welcomed, as they should be, into the communities where they wish to be. And they have the added protection of the fair housing law, which says that, for instance, that a drug problem is a protected category, is a disability, and therefore protected under the law, under the fair housing law. What this legislation tries to do is, consistent with the law, to give some comfort to all involved that the facility is being operated consistent with the state policy and standard, and that there is a single person of contact that, whether it's the neighborhood president, a resident of the community, or they're acting through us as their elected officials, that there would be an individual with responsibility to inform the affected neighborhood about the license conditions, and I think most significantly, after the license is granted, the community is being aware what are the standards for this facility, and if those standards are not being met, to bring that to the attention of the relevant state agency. Until I worked on this bill, I didn't know that there was such a standard, and that this was I believe, a legal option available consistent with the fair housing law. Are people meeting the license? Is this facility being operated consistent with the license it has been granted? The Department of Health had indicated to me that it is neutral on the bill, but I must say, being honest with its fiscal note, I'm not so sure how neutral they are. As the fiscal note says, there must be 2 people hired to respond to calls and inquiries regarding the license standard, and the two people makes it over the limit that we currently have for a fiscal note. So that's something that if the committee is going to move further or wishes to move further, that we will need to address with the department. This is a problem that we all have to deal with when we go back home. It is not one of the favored parts of the job to have to be an advocate for a neighborhood that is not taking into account, has not spent an afternoon like we have, listening to how people's lives can be measurably improved by being in a neighborhood facility. But it's very difficult to make that argument to the people that we represent. And this bill is an attempt to, within the bounds of the law that protects these folks, to also provide some, I think if the standards are applied or adhered to, which is what this bill seeks to bring about, it's a better environment and a better life for all concerned. Thank you.
Thank you, Delegate. I appreciate the bill. I'm looking around for questions. I think everyone is sort of holding their breath on the fiscal note, as you mentioned, Delegate. Okay, not seeing any questions. Thank you. And I'm going to call up an unfavorable person, and is Randy Ames in the? Go ahead and bring Randy up. So Matt, you want to come up to the table?
Thank you, Madam Vice Chair.
Take any questions? Thank you. And get that mic as close to you as you can, please.
Certainly. Good evening, Madam Vice Chair, members of the House Health and Government Operations Committee. My name is Matt Rice. I am the Executive Director of People on the Go of Maryland, which is Maryland's statewide self-advocacy organization ran for and by those with intellectual and developmental disabilities. I'm also a member of the Developmental Disabilities Coalition, which is 5 statewide organizations dedicated to advancing the rights and opportunities for people with intellectual and developmental disabilities. I am here in respectful opposition to HB 1136 because while I acknowledge what Delegate Rosenberg's intentions are, and I just want to put that up front, I believe this will unintentionally create a not in my backyard mentality. And if you have talked with anyone who has worked in a group home as staff, what they will tell you is they are constantly harassed, for lack of a better term, by the neighborhood about whether the trash cans are in the proper place, whether the parking spot is being taken up by the bus, or what have you. But I think what is clear is that we're talking about environments that are supposed to be individuals' homes. So how would you like to be treated by your neighbor? I do not believe, having had problems with my neighbor who doesn't have a disability, that they would like it if I had the ability to complain about them and how they live. So I respectfully ask for an unfavorable report on this bill, and let's not have a not in my backyard mentality for some of these most vulnerable people. Thank you.
Thank you, Matt. So that was your phone that was you were timing yourself? I
did.
So I have the first question. Is there anything else you'd like us to know?
You know, I think that what it comes down to is really people need to be willing to talk with their neighbors. For example, I own my own home. However, I had an issue with a neighbor of mine bringing a shed into my yard because she had to do that. She didn't have access to her property. She did that without my permission. And if I wanted to, I could have made a real issue about that. But I told my staff, please just ask her to come and talk to me and we will work it out. That's what we really ought to be doing for people regardless of their living circumstances. These are people's homes. These are not only facilities.
Thank you very much, Matt, and thank you for your patience and endurance in waiting today.
It's all part of the job, Madam Vice Chair.
You know it well, don't you? Questions for Mr. Rice? I'm looking carefully. Oh, and I'm looking at the wrong side. Delegate Woods.
Thank you, Madam Chair. Thank you so much for your testimony. I guess what I'm not clear about is I was under the impression that what Delegate Rosenberg is talking about are residential facilities, i.e. not private homes. Could you please provide some clarity?
So yes, that is what this bill references. I want to be clear that POG represents people who get services in group homes. When I gave my example, it was just an example of what what could potentially happen, and the example of the person complaining about the parking space and the trash cans, that was provided to me by a staff that I have that actually had the privilege to work in a residential facility, because he was told, when I talked to him about this, he said, I understand. He said, I understand why you fear this, because we constantly had to endure harassment from the neighborhood. He worked for United Cerebral Palsy, so nobody should have to experience that.
Okay.
Madam Chair, thank you so much again for your testimony, for sharing your experience, and I'm so sorry to hear that people can be so inconsiderate. Thank you again. Thank you, Madam Chair.
Thank you. Seeing no further questions for this witness. Thank you, Matt, for being here. And we're going to call on Randy Ames.
Good evening, Madam Chair and committee members. My name is Randy Ames. I'm here on behalf of Disability Rights Maryland, the statewide protection and advocacy agency for people with disabilities. And I'm also a member of the same coalition as Matt, the Developmental Disabilities Coalition. House Bill 1136 is singling out people with disabilities, in particular people with developmental disabilities, behavioral health conditions, and substance abuse disorders, despite similar community settings like assisted living facilities not being included in this bill. People with disabilities deserve the same privacy and autonomy that we all enjoy in our homes and neighborhoods, but they also deserve to have their status as a person with disability to be kept confidential. The Federal Fair Housing Act guarantees a person the right to equal access to housing opportunities and seeks to eliminate discrimination in housing based on protected classes, including disability. This bill runs the risk of potential violation of the Fair Housing Act. Next, complaint systems already exist. DDA has designated the Office of Healthcare Quality to monitor and inspect its licensed providers, which includes investigating complaints. OHCQ already has a robust complaint system that anyone may utilize. Similarly, the Behavioral Health Administration has a robust, accessible complaint system. The requirements of this bill are duplicative. It runs the risk of the complaint system being abused as a means to target and harass people with disabilities and may potentially violate their civil rights. The fiscal note amount and the Maryland Department of Health stating that they would have to designate two staff members would be needed, supports this risk of overuse and abuse of the process of the proposed complaint system. If there are serious health and safety concerns and complaints that are not being addressed, then further investigation is needed. But the problem and community concerns need to be clearly defined, and such problems need to be addressed through alternatives such as work groups or report to the General Assembly. And for those reasons, DRM opposes House Bill 1136. Thank you.
Okay. Thank you very much for your testimony. Looking around for questions from the committee. I am not seeing any, so thank you very much, Ms. Ames, for staying and waiting us out today. I appreciate it. That concludes the hearing on House Bill 1136, and we're going to go to House Bill 1083. Delegate Woods, that's you. Maryland Department of Health Work Group to implement early and periodic screening, diagnostic, and treatment requirements. And you have Ann Geddes, Ann Seacott, and Joyce Harrison.
Thank you, Madam Chair. I'm here with the Dream Team.
Indeed.
Excited to present testimony for House Bill 1083, Maryland Department of Health Work Group to implement early and periodic screening, diagnostic, and treatment requirements. Good afternoon, Madam Chair and esteemed members of the Health and Government Operations Committee. For the record, I am Delegate Jamila Woods, and I'm here to request a favorable response for House Bill 1083. This is legislation that's designed to align Maryland's Medicaid behavioral health system with federal recommendations for the early and periodic screening, diagnostic, and treatment, otherwise known as EPSDT services. As policymakers, our responsibility is to ensure every child in Maryland has access to care they need when they need it without unnecessary barriers. Yet under current policy, children who are seeking behavioral health services often must first receive a formal diagnosis before accessing care. This requirement contradicts the best practices outlined by the Centers for Medicare and Medicaid Services, otherwise known as CMS, and places a burden on families with young children. Children, especially in their earliest years, express their distress through various behaviors, including biting, aggression, sleep disturbances, and more, and often they are not expressed through words. A formal diagnosis in this critical stage can be premature, leading to mislabeling and stigmatization when not appropriately addressed. HB 1083 creates a structured, expert-driven work group within the Maryland Department of Health to study and implement necessary reforms, ensuring behavioral health care for our youngest, valuable, and most vulnerable populations is accessible, appropriate, and aligned with federal guidelines. This legislation is not just about compliance, it's about impact. We've heard from experts across the field, child psychiatrists, behavioral health advocates, and clinicians who've observed firsthand the harm that diagnostic barriers create. A child experiencing distress due to trauma, family separation, housing instability, parental mental health challenges, and more should not be denied services simply because they have presumptuously been provided a diagnosis which appears in their ongoing file. The work group will explore solutions, including the use of the DC 0 to 5 diagnostic classification system, and ensure the interventions are timely, developmentally appropriate, and community-based. Individually, most and collectively, all of us have suffered from the results of waiting until a crisis occurs in order to react because we failed to be proactive. We have the opportunity today to advance a model of care that is practical, equitable, and rooted in best practices. For this reason, I am asking your favorable response to HB 1083. Thank you so much.
You're welcome. Who will be next?
Welcome back, Madam Chair.
Yes, we have meetings with different departments.
Yes, Lord.
So we met today with the Department of Health, Department of Human Services, the Board of Mortician, the Governor's Office, all of that while we have hearings.
At the same
time. It's been a long day for you.
Yes, we have.
But good evening, and good evening, members of the committee. Thank you so much for having us. My name is Joyce Harrison. I am a medical doctor trained in pediatrics and child psychiatry, and I have worked over the past 3 decades at Kennedy Krieger and Johns Hopkins in the area of infant and early childhood, which, yes, it is a thing, psychiatry. I'm an associate professor of psychiatry at Hopkins, responsible for training our future generations of psychiatrists. But today I'm also here in my role as the immediate past president of the Infant Mental Health Association of Maryland and DC, which is a not-for-profit affiliate of the World Infant Mental Health Association, whose mission is to promote healthy social, emotional, cognitive, and physical development in infants from preconception to early childhood. And all of those things are tied together because they are bundled in this population. Part of my mission today is to help you understand how complicated it is to make these diagnoses in this young age group, which is why the CMS guidance would really remove so many of those barriers which Delegate Wood so articulately expressed. So, unbelievably significant mental health problems do occur in very young children, and they have lifelong impacts. At this age, as we heard, children really have a limited repertoire for expressing that distress. They come to us, and they come to pediatricians, and a lot of my work is in the interface between pediatrics and child psychiatry. They come to pediatricians with severe behavior problems, and pediatricians are at a loss with how to manage them, where to refer them, how to make a mental health or behavioral diagnosis. So the challenge is that many, many underlying factors can result in the same exact behavior, and so solving that mystery of what it is the challenge. And it's a process. It's not a 1, 2, 3 visit process. Sometimes for me, as an expert in this area, it's a several-month process. So please vote favorably on this bill.
Thank you for being here. We appreciate you, and thank you for what you do. It makes a difference. Who would like to go next?
Hi, thank you, Madam Chair. I will. I'm Ann Geddes. I'm the director. Thanks. I'm the Director of Child and Older Adult Policy at Mental Health Association of Maryland, and in that role, I chair the Children's Behavioral Health Coalition. I'm here in support of House Bill 1083. As was said, CMS recently published guidance stating that states should avoid requiring a diagnosis that a child have a specific behavioral health diagnosis in order to receive services, particularly if the child's under the age of 5. This is not the current policy in Maryland, which requires a provider to render a diagnosis within 3 sessions in order to receive reimbursement. House Bill 1083 asked the department to develop a plan to determine how they will revamp the current policy to align Maryland's practices with this new CMS guidance. This change is needed for the reasons stated by Delegate Woods and Dr. Harrison. I just wanted to add, we've been in conversations with the department, and we're close to coming to an agreement about how best to implement this bill, and expect that that will be done soon. Thank you, and I urge a favorable report.
One of my questions. You got in front of it. Go ahead.
Thank you, Madam Chair. Members of the committee, I'm Ann Seacott, wearing 2 hats tonight, the Maryland chapter of the National Council on Alcoholism and Drug Dependence, and a national group called Inseparable, a national advocacy organization on mental health issues, especially with children's mental health. We're here in support of the bill. We thank the sponsor very much for her passion on this issue. You saw us here last year talking about a bill that would have mandated that coverage in Medicaid for kids be allowed regardless of diagnosis. That came with a hefty fiscal note. And so when the guidance from CMS came out in September, we thought that's the ticket. They are now saying this is a best practice, and what we did was decide to make our bill more palatable, less expensive, and come up with this work group. And so just to say that as Ms. Geddes had just said, we are, I think, within hours of having compromise language that will not significantly change the bill and still accomplish everybody's goals. Our main issue is to make sure that clinicians with expertise in children's mental health, especially young children, are part of the process, really in support, meant to be in collaboration with the department in developing and implementing a plan, as well as the families that are directly impacted. So with that, we ask for a favorable report.
Thank you so much. So I'm going to open it up for questions now from the committee. Are there any questions for Delegate Woods and her panel? Seeing none, thank you so much, okay?
Thank you.
Thank you.
And if you could just let us know as soon as you're able to work those amendments, if you can provide it to the subcommittee, please. Thank you so much for your leadership. This concludes the real hearing on House Bill 1083. Next, we have House Bill 1131, Delegate Vogel. Delegate Vogel, I know I saw you out there in the committee. Can you please come? And does he have a panel? Are you on Delegate Vogel's panel? Can you come up and have a seat? And let's be ready. Delegate Allen is here? Oh, you Delegate Allen, let's go with you. Okay.
Hurry before Vogel.
Hurry up.
No offense to Joe. I'll take my chance when I can get it.
Do you have a panel?
Virtually, Madam Chair.
Okay. So can you bring the virtual panel up, please?
Eve Wiley is the name.
We'll bring the person up so they can be up with you.
Great, thank you.
Good evening, and thank you for being patient and waiting. We have had a long day.
It's that time of year.
Yeah, thank you for
all the days are
understanding.
long. Yeah.
Thank you.
Am I good to begin, Madam Chair?
Yes, you can start.
Awesome. Madam Chair, members of the committee, and my 2 district mates, good to see you. My name is Delegate Nick Allen. I'm here today to testify in support of my bill, House Bill 95. HB 95 is one of those bills that I really wish I didn't have to introduce. It addresses an issue that, frankly, I think we can all agree we wish we wouldn't have to address. HB 95 deals with cases of fraud and assisted reproductive treatment. I want to begin by acknowledging how deeply personal and emotional this subject is for families and for anyone who goes through or has gone through such treatment. And I apologize in advance if I get emotional at any point, because this is incredibly personal for me as well. I think by now we have all heard of these cases, either on the news, on the internet, or on TV documentaries, where someone has taken a commercially available DNA home test and then learns, unfortunately, that they have half-siblings that they never knew about. In some cases, dozens of them. And what they inevitably learn in a lot of these cases is that the doctor who performed the treatment on their parents used their own reproductive material. And typically, these doctors didn't do this just once. They did it again and again and again, every single time without any consent of the patient. I simply cannot imagine going through such an experience. To learn after the fact that this horrible, unforgivable thing happened to you and your parents and your family. This is a crime that literally affects someone's entire life, someone's entire sense of identity, and it affects multiple generations of your family. We'll hear more from my panel about the incredibly steep personal cost of these crimes, but I'm going to return to what my bill is trying to do. So unfortunately, because people often take these DNA tests when they're adults, decades have often passed since this happened. And in some cases, the original victims, with the parents in this case, might have passed away. Maryland law currently offers a pathway for professional discipline of a healthcare provider who fraudulently provides assisted reproductive treatment. So that's the good news. Professionally, there is accountability. Unfortunately, that's where the clear-cut accountability ends. A patient who is a victim in these cases could assert civil claims, but the statute of limitations is incredibly short. It's only 3 years. And again, people are typically aware of these crimes for many years, if not decades. Additionally, spouses or children born as a result of this treatment and these crimes simply do not have a clear pathway to asserting any civil claims. Criminal liability may also be more difficult to prove, although a provider who does this could possibly be prosecuted for second-degree assault. The sad truth is that the potential criminal charges under current state law would be uncertain, especially when the crime occurred years or decades previous and evidence might be difficult to obtain. House Bill 95 would provide more certainty for these victims, and that's exactly what we're trying to do here. First, HB 95 establishes that this is a felony. I think that part is rather simple. It also creates standing for the victims as well as their spouses and children to file civil claims, and gives them more time to do so beyond the already established 3-year statute of limitations. There are also portions of the bill that deal with donors and the intent and consent of the donors and their human reproductive material. This bill is based on an Illinois bill, and we included those provisions in drafting. However, I want to state that if it's the wish of the committee to narrow the scope to criminal penalties and civil liability, then I would say my intent as a sponsor has been met. I also know there are concerns about whether or not this phenomenon is a common enough problem, or whether this has occurred in Maryland. The simple fact is, aside from some high-profile stories in the media, we simply do not know how prevalent this issue is in Maryland or anywhere else in the United States. Firstly, commercially available at-home DNA tests are really only a decade or so old. Additionally, in most states like Maryland, where a clear pathway to criminal prosecution and civil liability does not exist, victims are left with only a handful of choices. They can either say nothing and try to live their life as best they can, or they can try to seek some sort of settlement directly with the provider, which is typically done outside of court and includes strict non-disclosure agreements, and nobody knows about it. So on a fundamental level, I simply have to ask, how many victims is enough in Maryland or the United States to spur us into action? Just because no victim in Maryland has publicly come forth, that does not mean that they don't exist. And let's be clear, when we say victims here, we're not talking not only about the mothers, but also the spouses, the children, the grandchildren, the siblings, and everyone else in the family who is directly affected by these crimes and will be affected for the rest of their lives and for multiple generations. I thank you for your time and support, or your time and consideration. I also want to thank my panel, especially Eve, for being here and telling her story. I urge a favorable report and look forward to answering any questions you may have.
Thank you. Good evening. Miss Wiley? Yes.
Yes.
How are you?
Thank you. I'm good. How are you?
Doing well. Thank you for asking. You can go ahead and get started.
Okay, great. Thank you so much for having me today. My name is Eve Wiley. I am the product of fertility fraud, and I'm representing myself. And today I'm testifying in support of HB 95. My story has been widely documented in the media in a Netflix documentary. It's been the catalyst of change in 10 of the 13 state-level bills on fertility fraud. My mother's fertility doctor knowingly and intentionally swapped his sperm for the intended donor that my parents selected and consented to. Her doctor is my biological father, and this is something that I discovered when I was 30 years old. It directly impacted my child's ability to receive health care, as we were not aware of all of the health things that were in my family history. I was horrified to learn that there was not a civil or a criminal cause of action to hold this man accountable. In fact, the only form of potential justice was to offer a non-disclosure agreement that would allow him to continue to practice with his reputation intact. Because of a statute of limitations issue and in the absence of any law, the medical board was unable to take his license for over 5 years. In my 6 years of advocating for bills, I've identified over 80 doctors who have committed fertility fraud. The ones that I am personally aware of in Maryland, they never reached a legal point because of the lack of criminal and civil causes of action. Doctors and medical health providers are allowed to operate under a cloak of the anonymous sperm donor to impregnate their patients without their knowledge or consent. Doctors are not donors. And I'm here today to ask you for your support and help in passing House Bill 95 to protect patients who are using artificial reproductive technologies and to rebuild trust within the profession by implementing those guardrails for bad actors. Thank you.
Thank you. I'm going to open it up for questions from the committee. Delegate Shalega.
Thank you, Madam Chair. Thank you for being here. I'm not going to ask you the name of your doctor, but Dr. Jacobson is, you're nodding yes, is a infamous, I guess, I don't want to call him famous, an infamous doctor that did that out of Bethesda, I think, or somewhere in that area. But didn't he go to prison for that?
So what he had was obstruction of justice, and what he went to prison for was tanking women's cycles. So he was saying that they were pregnant when they weren't pregnant. So he actually his was a different thing, but he did commit fertility fraud because he did impregnate his patients.
Yes,
but he was held accountable for was a separate issue.
I got you. Okay, because he went to federal prison for, maybe not enough time. I can't judge that, but, good to know that it was not the other thing. So, thank you.
The only form of accountability for fertility fraud was the one out of Indiana, Dr. Klein, and he received a $500 fine for obstruction of justice for lying to officials.
Wow. Thank you. I'm sorry that you had to find out the way you did.
Delegate White-Howland.
Thank you, Madam Chair, and thank you, Delegate, for being here and for this bill. I wanted to know if you are concerned really with any potential impacts that this bill could have for this particular sector, given the current climate and landscape. And so can you expound upon that, please?
Absolutely, thank you. Yeah, obviously, any sort of chilling effect is not my intent, and that's the last thing I would want to happen. Like I said, fertility treatment and safe fertility treatment is a very personal priority for me. It's something that's very important to me. That's why I'm here. That's why I have this bill. And I also think, my short time. I think we came in the General Assembly together. I think in my short time here, I've also made sure I'm championing the access to treatment. Co-sponsor of the Speaker's Reproductive Freedom Amendment bill. So obviously those are concerns. These are things that are very, very important to me. I will say, however, that if we are serious about expanding access, we also want that access to be safe, right? And I think any chilling I cannot imagine what the chilling effect would be if someone were to publicly come forward in Maryland and it would be a high-profile case, and all of a sudden it was known that there is no pathway to justice in Maryland. All of a sudden, everyone in Maryland is aware that doctors who do this in Maryland, have a potential escape hatch. So I would be more concerned about that chilling effect. But it's something that, like I said, it's something that is very, very concerning to me. That's why, again, I'm willing to work with the committee. I'm willing to amend. I'm willing to focus. And I think it's something that we can figure out. Thank you.
Delegate Taveras.
Thank you, Madam Chair. I'm just trying to see if this bill also accounts for, because in a lot of these documentaries, it's not only the doctors, it's also the donors.
Right.
I think we were talking about this.
Yeah, I know we spoke about it a little bit offline.
Yeah, we had like the freeloading donors.
Yeah, there's so the portion in it, like I mentioned, the portion from the Illinois bill that talks about the use of the reproductive material in a manner that is inconsistent with the consent of the donor. That's part of that, because a lot of times when a donor goes to a clinic, they sign, different forms, different release forms, but they pledge to not donate more than so many times. The clinic promises not to use their sample more than so many times, or to stop using it once it successfully results in so many conceptions. So I think that's the part of the bill that's trying to address that, is the kind of serial donors, because no reputable clinic would actually let someone's sample be used that many times. But if someone is fraudulently donating that in that way, that would seek to combat that as well. But again, if the committee is concerned about if there's better ways to go about that, then again, I'm willing to look at that and see, maybe again, if we want to focus on the providers, that might be the way to go too.
Yeah, we could talk about it, because there could be multiple, they could go to multiple places. That's the
Yeah,
issue.
right. Well, I mean, different states have different rules, different countries have different rules. Yeah, it's very complex.
Thank you.
So I don't see any other question, but Delegate Allen, I know you and I met.
Yes, ma'am.
And the State Board of Physicians in Maryland, right now, the State Board of Physicians enforces Title 14 physicians and Title 15 physician assistants of the health occupations article in the Maryland Code Health Article 14-205. They have 2 disciplinary panels consisting of members of the State Board of Physicians that resolve complaints against a licensed physician or an allied health professional. After following the necessary procedures, and this is in the letter that we got from the AG, and an affirmative vote on a majority of the court, the disciplinary panel can do the following in this case, right now, today, without a bill. They can reprimand, place on probation, suspend or revoke a license if the licensee commits certain acts. A disciplinary panel may also issue a cease and desist order or obtain injunction relief against an individual for taking action on which a disciplinary panel determines is a preponderance of the evidence on grounds for disciplinary action under that code. They may also summarily do suspension of a license. There are few disciplinary grounds under Section 14-404 that could be relevant here, according to the AG, including but not limited to making a willful misrepresentation in treatment, being guilty of immoral, unprofessional conduct in the practice of medicine, which this will definitely be.
Absolutely.
Failing to meet appropriate standard as determined by the appropriate peer review, which this will definitely be, right? And they go on to many other. So I would say that this is already covered, that what you're probably looking for, which it's not our jurisdiction, and I spoke with you, is criminal, action, which will be the Judiciary Committee. And I would say that would probably be, the best course of action, because under our professional State Board of Physicians, they already can discipline someone like this. However, we cannot, and you're right, in Maryland, hold someone criminally responsible, but that is not the article that we work on in this committee.
Understood.
So I don't know, and I know you and I talked about it, and it's not, as you know, I cannot take on a Judiciary Committee bill, right? And we can continue to talk about it offline to see what we can do. Have you talked to the Judiciary Chair about this bill?
I spoke with the Vice Chair earlier this week, and she was just asking about the status of the bill in this committee.
Can you do me a favor and make a meeting to speak with the Judiciary Chair?
Yes, ma'am.
And share the letter with him and my suggestion regarding the criminal code. Okay?
May I add
Will do.
something that's been
Sure.
previously identified? So a lot of these doctors, what they say in the medical board hearings is that they were anonymous sperm donors, and that's how they operate under the cloak of anonymity. And then a lot of the medical boards, in my case in particular, they came down to standard level of care versus unethical conduct and behavior, which didn't have a statute of limitations and there wasn't a discovery rule. So we had to change the law again to insert a discovery rule around fertility fraud. But those were the two ways that, and he was able to file a restraining order against the medical board, so they couldn't serve him the cease and desist or the revoking of his license. And so there were like multiple complications. So something to consider. It could be different, obviously, but just wanted to bring it up.
Yeah, I think what I would like to do is, given the AG letter, which is pretty clear for me of what they can do, is also, I just talked to council, I'm going to send the board an email describing the situation and see what options they have. But I also would like Delegate Allen to speak to the Judiciary Chair and see if he has any interest in the criminal aspect of it.
Absolutely.
Does that sound okay?
Yes, ma'am.
All right. I do appreciate the problem, and I have to say, Ms. Wiley, thank you for sharing your story. I want you to know that it's important, right? Which is why we went ahead and got the AG letter and why we're exploring all these other options to see what really we need to do here, okay? And we thank you for sharing it, and I'm so sorry you have to experience and live through that.
Thank you. I appreciate it.
You're welcome. I don't see anyone else with any other questions. Thank you so much for being with us. We do have Delegate Allen. We have an unfavorable that we're going to hear now, and then we have another favorable, okay? Yeah. I'm going to call the unfavorable just to be balanced, and we have Deborah Brocato virtually. Will you be so kind and give us your testimony? She's what? Oh, she's right here. Ms. Brocato, good evening. Hi, can you give us your testimony, please?
Yeah, can you hear me?
Yes, we can.
Okay. All right, good afternoon, Deborah Brocato with Maryland Right to Life, and on behalf of our Board of Directors and followers across the state, we do oppose House Bill 95. First of all, we do oppose anything that allows the destruction of human life, which IVF does allow. But also, Maryland Right to Life favors informed consent, but this bill does not guarantee the information provided is medically accurate and comprehensive. We are particularly looking at the exploitation against women donors. Women are reduced to sources of human reproductive material. A woman's fertility and her life are at risk. Egg donation means hormone injections for 10 to 12 days, then surgery under anesthesia to retrieve the eggs. Every female is born with a finite number of eggs. At puberty, there is egg maturation, ovulation, menstruation, or pregnancy. Every menstrual cycle decreases the number of eggs available to conceive a child. Likewise, donation of eggs decreases availability of eggs for conceiving a child in the future. The number of eggs harvested varies, and a woman doesn't know how many eggs she will lose. While in college, my daughter and other girls were approached to sell their eggs for $5,000. She refused, but thankfully called me. I gave her the facts, which she shared with her friends. You can see how vulnerable women and girls could easily be exploited. Due to the Reproductive Freedom Amendment, minor girls are also vulnerable to this exploitation. There is nothing in this bill that would guarantee women and girls will know the full consequences and possible outcomes of harvesting their eggs. IVF businesses put profits over people. IVF is a billion-dollar business, and women are merely resources to be exploited. We ask that you protect human life at its earliest stage and protect women and young girls from the predatory practices that put their lives in jeopardy. We ask you to give an unfavorable report on House Bill 95. Thank you.
Thank you, and thank you for your testimony. Are there any questions for Ms. Brocato? Seeing none, thank you for being with us. We do have a favorable. William Kress, are you here? William Kress? Okay, I don't see him. that concludes the bill hearing on House Bill 95. Delegate Allen, can you let me know as soon as you can when that conversation takes place? And council will send a letter to the Board of Physicians, okay?
Absolutely.
Thank you. Have a blessed day. Thank you for working with us. My pleasure. Next, we're going to the last bill of the evening, House Bill 1131. Delegate Vogel, will you please bring your panel?
You have 1146.
I'm sorry, what?
1146, we haven't done yet. Don't go wait.
Oh no, but she's in here.
Oh,
Yeah, go ahead.
Madam Chair.
Yes.
Take a seat. Madam Vice Chair.
Oh,
sorry.
Council is right. This is not the last hearing, the last bill. We do have, she's right, Delegate White Holland's bill. Okay? Thank you.
Do you still want to take us now?
That's why she gets paid the big bucks. Just kidding. Go ahead.
Madam Chair, Madam Vice Chair, members of the Health and Government Operations Committee, thank you for staying so late tonight. I'm here with House Bill 1131, which is a piece of legislation to scale up the the administration of buprenorphine across the state. Before I start, I just want to give two quick shout outs. One to Councilmember Conway, who a conversation with him, he's been a leader on this issue in Baltimore City, and a conversation with him led to this piece of legislation. And then I have two fantastic Masters in Public Health Fellows, Sapphire Ferduzzi and Sam Nateau, who have been just so incredibly helpful in crafting this bill. So what House Bill 1131 intends to do is build out a training program, a training grant program to train Maryland's paramedics to administer buprenorphine in the field. You will hear from folks on this panel who can speak to the work that is already being done across the state on this front. And evidence shows that commencing buprenorphine in the field by paramedics, coupled with linkage to medical care, improves the retention rates and engagement in ongoing treatment for opioid dependence. As first responders, paramedics are some of the only providers who may interact with those suffering from an overdose. So I'll let the panelists here get into the details of how buprenorphine works and why it's so helpful. But we know that this is a best practice now for addressing the opioid overdose epidemic, for getting folks into treatment, for preventing future overdoses. And I will just note two things here. One is that the grant program is funded by Opioid Restitution Fund money. We have been closely coordinating with the Maryland Office of Opioid Response on this effort. And there is a need for a work group as well. And the reason that there's a need for a work group is because as we look at the administration of buprenorphine, we recognize that there's a period of about 24 hours after buprenorphine is administered where folks should ideally get into more permanent treatment, whether that's buprenorphine or some other medically assisted treatment. What we have a challenge right now in the state that many of you are very familiar with, which is a lack of treatment options. So what we need to build out with this work group, and we started having these conversations over the course of the session, but there's definitely more conversations to be had and more work to be done, is figuring out how we build that hub and spoke model so that once buprenorphine is administered, an individual can then be quickly referred within that 24-hour period to more continuous medically assisted treatment. So with that, I urge a favorable report on House Bill 1131, and we'll turn it over to Councilmember Conway.
Thank you, Delegate Vogel. Once again, my name is Mark Conway. I am a council member on the Baltimore City Council, representing the 4th District, and I am chair of the Public Safety Committee. And I have been absolutely obsessing over this issue after recent coverage about the impact of opioids in Baltimore City. For those that may not know, and I'm sure everyone does, given the work you guys do, Baltimore City has experienced a significant loss of life over the last few years, specifically 6,000 people, over 6,000 people in 6 years due to overdose deaths. And as we began to look at ways to address this crisis, one of the greatest opportunities for us, and one that we have used in the past, has been the administration of buprenorphine. Buprenorphine is a drug that can help people deal with addiction and can help stabilize their lives going forward. But even more, what we know is that in this moment, after someone has been resuscitated from an overdose, after they've received naloxone, they are most able to consider using buprenorphine as a maintenance drug going forward. that brief interaction after they've received naloxone and are in withdrawal, they're having the worst moment of their life after they almost lost their life. And what we want to do is make sure that we create an opportunity for them to make the next best decision to enter treatment and to enter recovery thereafter. This bill attempts to, one, help folks administer buprenorphine and equip our EMS teams out there with the drug, but even more, the work group is going to be really important in making sure that we address the care that exists afterward and making sure that people can continue that treatment after they receive that first dose in the field. So I want to urge a favorable report, and I am absolutely here to answer any questions that folks have. Thank you.
Next, please.
Hello, I am Drew Fuller. I'm an emergency physician and addiction medicine physician, and thank you for the accommodation to speak today. This bill has a significant opportunity for Maryland to lead the nation, and I'll explain that in a moment. It's been an honor to practice medicine in this state for nearly 3 decades, and doing so within the realm of public health, primary care, emergency medicine, and now addiction medicine. I practice complex co-occurring addiction medicine in central Maryland and serve many regions throughout the state. I went to become an emergency medicine physician to save lives. I transitioned to addiction medicine to save many more lives and to help save families and to serve communities. Buprenorphine is one of the safest and most effective treatments and likely one of the greatest opportunities to expand access to care in the state of Maryland. Our paramedics are highly capable and well-trained crisis providers. I see a day where every paramedic and every medic unit will be able to provide a stabilizing dose of buprenorphine to people in need and to help with that transition of care. Our EMS providers are on the front lines of this opioid epidemic, and we need to study how to best utilize their skills and services. For clarification, the majority of people who overdose now don't even activate the EMS system. The majority of those patients who do activate the EMS systems deny transport to a hospital, and nearly 50% of those people that get to a hospital deny care for various reasons. So this, is one of the greatest patient safety concerns and even a public safety issue. Unfortunately, this is not the only epidemic we face. We have an epidemic of no, where people don't have access to follow-up care. No, you can't get the care. No, you can't get it today. No, you can't get the right services. What we need is to turn no into now and to have treatment now and have a treatment-on-demand system 24/7, 365 for the state of Maryland. So Maryland can lead, I'll close in just one paragraph. Maryland can lead the way, not just in mortality, but in addressing the opioid epidemic and leading the rest of the nation in developing evidence-based transformational systems for universal access and the most effective treatments.
Next, please. And thank you for being with us today.
Good evening, Madam Chair, members of the committee. My name is Dan Rabbit. I'm the Policy Director for Behavioral Health System Baltimore. We're the local behavioral health authority in Baltimore City. We thank the delegate and the councilman for their interest in this issue. HB 1131 represents a creative approach to improve buprenorphine access in Maryland. There's what the providers think of as like a golden window. I forget exactly the term. But right after someone has an overdose or another medical emergency is a time where they may be considering treatment, maybe a little bit more open to treatment, maybe a little bit more open to engaging in care than they otherwise might be. So providing buprenorphine, which is a safe and effective medication that reduces cravings, that reduces the likelihood of relapse, that improves the engagement in treatment, kind of just like furthers that ability that someone may have to consider making a change and engaging in a way that they might otherwise not normally do. So we very much appreciate looking at this and investing in this as a creative, innovative way to expand access to buprenorphine. The work group that's at the bottom or at the end of the bill is also so important. We've done so much at the federal level to increase access to buprenorphine. We've increased the number of prescriptions a doctor can make. We've gotten rid of various regulatory burdens. And we've actually seen buprenorphine, or at least medication-assisted treatment, go down in Maryland over the last 8 years. More people were receiving care through medications in 2016 than today. And so we really need to look at what are the bottlenecks, what are the barriers, both to help folks who received buprenorphine through this kind of demonstration project or this new idea, but also just more generally, like there's sometimes a lack of stocking at pharmacies. There's sometimes it's just not accessible at different inpatient facilities. There's just a lot of different issues, and we really need to take a close look at it. So we really appreciate the bill and urge a favorable report.
Thank you. I just was reading the Maryland Office of Overdose Response letter and the Maryland Institute for Emergency Medical Services Systems letter, because instead of supporting, they both did letter of information, which is fine. Let me open it up for questions. Delegate Hill.
Thank you, Madam Chair, and thank you, Delegate Vogel. And since you said I had to ask you a question, I didn't want to disappoint you. But I think this is one, yeah, I know.
She asks the toughest question, so I knew it was coming.
I just need some education, I guess, from one of the doctors. Since buprenorphine, unless something's changed, generally requires at least 12 hours since a short-acting opioid before you can administer, and up to 72 hours if it was a longer-acting one. Why is this program right for paramedics? In other words, we can't be sure that that's been at least 12 hours by the time they show up.
Certainly, that's a great question, and thank you for asking. Often when EMS is being activated, it's after an overdose event, and the patient was given Narcan even by a bystander or someone on the EMS system, and they are thrown into severe withdrawal, and that's Narcan precipitated withdrawal. And when they're in that state, it's actually probably the perfect time to start buprenorphine, because buprenorphine can help ameliorate that withdrawal and then provide up to 1 day's worth of protection should they reuse to a degree. It's something that's not commonly known, even from our emergency medicine providers, and that's a knowledge transfer issue that we need to work on. But Maryland's leading the way even with that, with House Bill 1155 that passed last year.
All right, thank you.
And if I could add on, it's also important to note that there are instances where folks who are looking to get on a buprenorphine regimen will take naloxone to precipitate withdrawal in order to start their regimen more quickly. So this is sometimes used as a method for people who don't necessarily want to wait out until withdrawal.
All right, thank you, thank you.
You're welcome. All right? Okay. Delegate Taveras.
Okay, thank you, Madam Chair. Just, you said I would like it, but I don't know. I've gotten a lot of complaints on Suboxone because I deal with this problem as well in my district. And I take them to your district, probably, or Mount Manor, to get remedied, right? And they give them Suboxone, which contains this drug with naloxone. But is this too not addictive? It is. Don't you think? And the problem is that it's now even being promulgated in the streets. Have you not found that?
I'm sorry, I didn't hear the last statement.
Have you not found that this is becoming a problem, Suboxone, and this drug is now becoming a problem in itself in the streets because they're also getting addicted to this?
So we see very, very few cases where people became addicted to buprenorphine. Buprenorphine is an opioid, yes. It's a very, very safe opioid. And for clarification, we don't see buprenorphine overdoses. We don't see this in the state for many, many, many years. I think in the last 3 years, we saw one child who got exposed to buprenorphine and had an overdose. The thing that we see, there is illicit distribution that does happen, but you see that in systems where people don't have access to care, and that's where they'll get it. And so when people are buying buprenorphine on the streets, they're not buying it to misuse it. It's too easy to get an opioid right now. A fentanyl cap is $3 now in Baltimore City. So if people are using it for whatever reason, they're often using it to help maintain avoidance of withdrawal symptoms. And the data shows that if someone buys buprenorphine illicitly on the street, they're less likely to overdose and die, number one, and then they're more likely to actually come into long-term treatment. So while buprenorphine is an opioid, it's really the treatment of choice and considered the gold standard, and one of two treatment modalities that have been shown to extend life and reduce overdose deaths. none of our other treatments within the addiction medicine continuum have actually been shown to decrease the death rate.
Okay.
Dead addicts don't recover.
Well, we could talk about it in the subcommittee, because I'm seeing that's when xylene comes into play. But all right, thank you.
Yeah.
So, for the doctor, can you tell me where you practice?
I have a practice in Glen Burnie known as Brightwell Health, and we're a complex addiction medicine service that does co-occurring mental health, and we're one of the training facilities for Johns Hopkins addiction medicine.
So you see a lot of cases, correct?
Quite a few. That's all I do, all day, every day.
Okay. So you know how the drug works?
Very well. I've been doing this for 6 years. I gave the drug a few times when I was in emergency medicine at Bayview about 20 years ago, but for a period of time in emergency medicine, wasn't able to give it. And then once I learned about the science of the benefit of buprenorphine, I realized it is a much more beneficial treatment than 95% of what I was doing in emergency medicine, and that includes stroke care, heart attack care. So buprenorphine can save more lives than stroke treatment. Buprenorphine can save more life years than even in cardiac care. That's not my statement. Those are actually facts when we look at saving young people over time. It's an incredibly effective treatment. And I was asked by the director of the Calvert County Health Department to advocate for buprenorphine in Calvert's emergency department. And I was resistant at the time, thinking it was a bridge to nowhere. And then when I did the treatment and I saw how effective it was, I was actually embarrassed about the lack of treatment that I was providing as an emergency physician for 15 years. So in my 30 years, this is literally the single most effective treatment for saving lives and for impacting families.
And do you know every year how many people we have that died from overdose?
I do, and I would say just for the committee, it's an undercount. So just to remind the committee, even nationally, it's 100,000 people have died of an overdose. That's an undercount because those are only confirmed overdose deaths. There's a large portion of people, when I was an emergency doctor signing death certificates for people that we didn't really know how they died, but the medical examiner declined to see them, that we had to assign a diagnosis to. And then there are other states that even failed to list opioids, Florida being one of them, as a cause of death. So it's estimated that the number could be 25% higher for the total count, and that the number proportion involving opioids could be 20 to 40% higher.
Yeah, I think we heard a bill last week in this committee where it stated that every year in Maryland, we have, I think last year it was over 2,000. The year before it was like close to 2,000. So, and that is on the county. You're absolutely right. Thank you for the work you do. We really appreciate it.
Thank you.
Any other questions?
Madam Chair, if I could add a note.
Will you like me to ask you a question? Tell me, go ahead.
Yes, please, about Baltimore's experience rolling out buprenorphine in the past.
Okay, what would you like to tell us? Because we're supposed to ask the question. So what would you like to tell us?
I would like to tell you, Baltimore has actually rolled out buprenorphine in the past, in the early 2000s, under then Health Commissioner Josh Sharfstein, who then became Health Commissioner for the state, or Secretary for the state. We rolled out that program and saw a significant decrease in overdose deaths. Buprenorphine works, and it works really, really well. I think what we've seen recently is less use, and I think what this bill is attempting to do is to find a novel way to introduce it into the workflow of everyday interactions with folks who are experiencing overdoses.
Can I ask you a question?
Yes.
The restitution fund, and I know Baltimore City was able, and congratulations on your lawyers, obtain an amazing award. Do you plan to use some of that money for some of this work?
I can't answer that question yet because we're still in court, hopefully, to get much more money than we already have right now. So unfortunately, I can't answer that publicly.
Okay. Well, good for you. Yeah. And I hope and pray that, I went and took a tour of some of the treatment facilities that you have, and you guys are doing state-of-the-art work. Like, you're really out there. So thank you for your work and your leadership, okay?
Thank you.
You're welcome. I don't see any other questions, so I'm going to go ahead to, there's no unfavorable, so I can't say I'm going to an unfavorable panel. So let's go to the next three witnesses left on this bill, which is Charlotte Fleckenstein and Matthew Borgen and Patrick Schock. Good afternoon. How are you?
Good, how are you?
Good. Would you like to get started, please?
Sure, absolutely. Good afternoon, Madam Chair, members of the committee. My name is Charlotte Fleckenstein, and I'm the Policy Fellow with the Maryland Association of Counties, testifying in support of House Bill 1131. We thank the sponsor for bringing this bill forward and for recognizing the need for such an important piece of legislation, especially to protect our most vulnerable as the opioid crisis continues to devastate our communities. Establishing this buprenorphine training grant program and its work group will assist counties who are on the front lines of the opioid crisis every day with offsetting the costs of training paramedics to administer buprenorphine. This legislation represents a significant step forward in Maryland's ongoing battle against the opioid crisis by ensuring that first responders have access to provide critical life-saving care. Programs like the Frederick County Community Outreach and Support Team, or COAST, have demonstrated the impact of such important interventions. COAST's team of paramedics and peer recovery specialists provide medical care and emotional support to address both immediate and systemic needs through scene response, follow-up visits, and community outreach. This program is one of many phenomenal examples of the critical programs the work group could explore and enhance, and the life-saving initiatives this funding would support. Again, we thank the sponsor for introducing this bill as it provides a much-needed tool to expand access to effective life-saving interventions. For these reasons, MACO respectfully urges a favorable report on House Bill 1131. Thank you.
Thank you for being here. Appreciate you. And for all of you for being patient. It's so late and you're still here. So next, please.
Good evening, Madam Chair, Madam Vice Chair, and members of the Health and Government Operations Committee. My name is Matthew Bergen, and I appreciate the opportunity to testify in support of House Bill 1131. I am a board-certified community paramedic with the Frederick County Division of Fire and Rescue Services with extensive experience in caring for individuals impacted by opioid use disorder. I also served as the lead author on Maryland's statewide EMS protocol allowing community paramedics to administer buprenorphine. The opioid crisis continues to devastate Marylanders. EMS clinicians revive patients with naloxone daily, yet many decline further care, leaving them vulnerable to another overdose. House Bill 1131 will help break the cycle by funding paramedic training on buprenorphine, a proven medication that reduces withdrawal symptoms and bridges patients to treatment. In my jurisdiction, 3 paramedics have been trained to administer buprenorphine for withdrawal with promising results. The intervention prevents overdose recurrence, eases withdrawal symptoms that drive illicit substance use, and normalizes dopamine levels, helping patients engage in treatment. With her permission, I'd like to share the story of a patient I had the privilege of meeting. In severe opioid withdrawal, her grandmother drove her and her 2 young children from the next county over to meet my team for help. When she arrived, she was curled up in the passenger seat of her car, barely responsive, a shell of herself. By the end of our brief visit, she was alert, smiling, and grateful. She felt like herself again. But she was also confused. Why couldn't the paramedics in her hometown provide the same treatment? Proper training is essential for safety and success. Paramedics routinely administer life-saving medications, but buprenorphine isn't just any medication, and it shouldn't be administered by just any paramedic. Training such as motivational interviewing, awareness of local treatment options, and social support navigations are not topics covered in the routine paramedic curriculum. House Bill 1131 ensures jurisdictions can provide this crucial training, empowering paramedics to administer buprenorphine safely and effectively. I urge your favorable report on House Bill 1131, and thank you for your time and consideration.
Thank you for the work you do, okay?
Yes, ma'am. The pleasure's ours.
Lives. Next, please.
Good evening, Madam Chair, Madam Vice Chair, and thank you to Delegate Vogel for introducing this important piece of legislation. I'm Patrick Schock. I'm a board-certified preventive medicine physician, and for identification purposes, I'm a clinician with the Project Connections at Reentry, which is a nonprofit Baltimore-based program that provides low-barrier care for people with opioid use disorder. I'm also a member of the Baltimore City Health Department's Syringe Services Oversight Committee, which I also used to run when I was at the Health Department. Both of these experiences have allowed me to personally interact with thousands of people suffering from opioid use disorder, and I'm testifying today as an individual only on my own behalf and not for any of these organizations. Maryland saw about a 34% decline in overdose deaths in 2024. Almost all, 84%, were related to opioids. While this is welcome news, there is still more that we need to do and can do to reduce these tragic deaths. The public is increasingly aware of the value of naloxone in resuscitating someone experiencing an opioid overdose, but much is being done to make naloxone widely more available, like the Maryland Office of Overdose Response, which is certifying harm reduction programs around the state. But naloxone is only part of the success story about how to handle overdose. Naloxone rapidly displaces, as my colleagues have said, opioids, leading to the return of respiration, but it can also result in painful opioid withdrawal. Symptoms are very severe: agitation, abdominal pain, vomiting, muscle pain, cramping, and irritability. These contribute to an existing already chaotic scene and confusion for the patient. Withdrawal is especially true if more than one dose of naloxone is required, or the patient has used one of the newer, longer-acting synthetic opioids, which can outlast the effects of naloxone. So the treatment for this withdrawal is administration of buprenorphine, which will reduce the symptoms, stabilize and calm the patient. Although administration of buprenorphine has traditionally been done after the patient has been taken to the hospital, our experiences here and elsewhere are that most patients don't go to the hospital. About 45% of patients refuse transportation to the hospital for a number of reasons, and so field initiation of buprenorphine becomes even more important for this process. After the patient's naloxone has lost its effect, which is usually about 60 to 90 minutes, a person using longer-acting synthetics can experience a relapse again with an overdose. And for those people who do not get buprenorphine, they run about a 5 to 10% chance of relapsing again, and the important point is that most of these occur within the first day or two. So field administration of buprenorphine by paramedics has been shown around the country to create a less stigmatizing atmosphere for patients, increase subsequent transportation to the hospital, and produce a higher rate, up to 78% of engagement in further care and addiction treatment. So in conversations with program staff I've had around the country, there's been unanimous support for including peer recovery specialists as part of this team. The peers with lived recovery experience bring knowledge, trust, and connection to the EMS encounter, and most of us in the field of addiction treatment have found such experienced peers really essential in helping patients navigate the complicated recovery process. So to conduct quality training of paramedics for the administration of buprenorphine in the field of management of overdose, we really support this legislation, which will create the training system possible to make this work. Thank you, Madam Chair and committee members, for the opportunity to testify on this bill.
And thank you so much for being here. We appreciate your testimony. Are there questions for this panel? Seeing none, thank you so much. You have a safe return home, okay? This concludes the bill hearing on House Bill 1131. So we are going to the last bill of the day, which is Delegate White Holland, and it is House Bill 1146. All right. All right. House Bill 1146, Delegate White Holland, Maryland Behavioral Health Crisis Response System, integration of 988 Suicide and Crisis Lifeline Network, and outcome evaluations. That is a long title.
Yes, it is.
Go ahead.
Okay.
And thank you, everyone that's waiting for this one. This is the last bill hearing. Thank you for being patient, okay?
Well, good
You can get started.
Thank you, Madam Chair. Good
You're
evening,
welcome.
Madam Chair, Madam Vice Chair, and members of the House Health and Government Operations Committee. For the record, I'm Delegate Jennifer White Holland, have the pleasure of presenting HB 1146, Maryland Behavioral Health Crisis Response System integration of 988 Suicide and Crisis Lifeline Network and outcome evaluations for your consideration. HB 1146 is an opportunity to take another step that seeks to strengthen our mental and behavioral health continuum of care, specifically our behavioral health crisis response system. This bill does the following. It formally incorporates 988, Maryland's crisis response in statute, which will ensure proper coordination across the state. Secondly, this bill seeks to improve crisis outcome measurement and transparency to ensure there are clear, standardized metrics to better assess our system and determine where additional investments are needed.
before turning things over to the dynamic Dan duo, who will expound further, I wanted to speak to some of the amendments proposed by the Maryland Department of Health and Montgomery County, which you will see in your floor system. We reached out to the Maryland Department of Health, Behavioral Health Administration in advance, and after our discussions, we accept their amendments outlined on page 2 of each of their testimonies that were uploaded, and we accept these amendments as friendly. Concerning the 2 amendments outlined in Montgomery County's testimony, we will discuss this further between the department and Montgomery County, and certainly in subcommittee. Regarding the fiscal note, to be honest, this was a little surprising, since this data is already being collected and the report is required. This bill simply clarifies without adding any new responsibilities. We appreciate the Department of Legislative Services acknowledging that report writing can be absorbed within existing resources. And we also understand and acknowledge that the Maryland Department of Health needs staff, essentially a part-time epidemiologist, to fully implement their data collection systems. Paired with that, it is possible that the amendment offered by Montgomery County could massage the fiscal note further by delaying the first annual report to 2026. Again, we have yet to discuss this with stakeholders and look forward to working this out. For these and other reasons, I respectfully request a favorable report. Thank you for your consideration.
The first Dan.
Yeah. Good evening again. Dan Rabbit, Policy Director at Behavioral Health System Baltimore, for the record. I think the Delegate White Holland, explained this quite well. This bill came from BHSB and our partners in the coalition that worked on 988 legislation over the last few years, looking for an important but modest step forward. We really appreciate all the work that the General Assembly has done, that this committee has done in recent years to invest in the 988 helpline, to invest in crisis services, to further the infrastructure that the state has to make those services work well. This bill was just trying to accurately reflect how things work today with 988. The statute that describes the Maryland crisis response system was drafted before 988 existed. So we wanted to go back and make sure that 988's important role is accurately reflected in the way that the system is described in statute. And we wanted to clarify and kind of guide the annual report that the department is supposed to provide regarding crisis services, to make it along the lines of the way the crisis services are generally looked at today, which is along the crisis now model, someone to call, someone to respond, and somewhere to go. And so we lay out some kind of a floor of metrics that we'd like to see reported each year. The Department of Health's amendments are completely friendly, and we've had a chance to talk to them about it, and we look forward to discussing the other amendments as well. I will say on the Senate side, they are comfortable with the fiscal note. I know each side has different rules, but we're hopeful that that can move along.
Yeah, it's different here, 75 or less.
75? Mm-hmm. It's only 60.
Okay.
Hey.
But we can try to massage further. We'll see.
Well, you can
it's a late night miracle. Yeah.
You can continue to massage. All right, the other Dan.
Madam Chair, members of the committee, Dan Martin with the Mental Health Association of Maryland. Happy to be here with you tonight, and I'm going to take everybody on a trip down memory lane. I think that'll be a nice way to end a long day. There's been so much progress in this area, dating all the way back to 2002 when Delegate Rosenberg himself sponsored the legislation that created Maryland's mental health crisis response system and statute with the goal of ensuring access to a statewide network of services designed to treat people in crisis, divert them from the emergency department, the criminal justice system. And we've been working for nearly 25 years to realize that vision, and we're closer than we ever have been before. thanks to the work of so many folks in the community, so many stakeholders, the state, and especially the folks here in the HGO Committee. And so again, a little trip down memory lane. After that 2002 bill in 2015, Delegate Rosenberg and HGO spearheaded legislation to bring substance use into the system and make it a behavioral health crisis response system. Then in 2016, you all required Behavioral Health Advisory Council to develop a strategic plan for walk-in and mobile crisis response teams. In 2018, HGO really spearheaded the effort to establish the Behavioral Health Crisis Response Grant Program. In 2020, you all passed legislation allowing crisis response centers to be considered designated emergency facilities. That was Delegate Bagnall's bill for purposes of people being served emergency petitions. And then in 2022 and in 2023, you all created the 988 fund and then funded the 988 fund. And so again, there's been so much work done. Maryland's crisis system is as robust and as effective as it ever has been. And as thanks to the work of so many, again, particularly the work of you all here on HGO. And this bill is just going to help us make sure that as we continue to build out the system, we're doing it in a data-driven way that is strategically addressing gaps in care across the state. And so I urge you to continue the great work and pass this bill, and thank you for everything that you've done.
HGO rocks.
HGO rocks.
We are quiet, humble,
rock,
but
though.
we rock.
Damn right.
Okay? So let's open it up for questions. Any questions? All right. Oh, go ahead.
Yes, ma'am, because everybody wants to leave. Just quick question. Have you touched base with a lot of the crisis lifeline centers that we have across the state? Because we have a crisis hotline in my district, or what used to be my district, and I just want to make sure that how disruptive would it be to their regular services?
Well, Dan works for a crisis lifeline.
This came from the Maryland 988 campaign coalition, which has all 8 988 call centers represented. A lot of this data is already collected, both due to federal regulation and state and local. And so this is more taking the data that we already have and packaging it in a way that is comparable and transparent and easily findable. It shouldn't create new burdens on any providers.
Any of the centers?
Any of the centers, any of the call centers.
Okay, thank you.
The beauty of 988 is that it's all in one place.
Yep. Yeah.
All in one place, and it's designated to be, the suicide hotline nationwide.
Yep. And that's what this bill does, is it says 988 is the coordinated point of entry for the system.
Makes sense.
Yep.
Anyone? Oh, Delegate Rosenberg.
Well, thank you. Now that it's 2025, we've been dealing with people in emergency rooms for far too long. We experienced that and had to deal with that with people who had mental health issues who were in, if not the emergency room, in the hospital for a longer period of time than was appropriate. How did we solve, to the extent that we've solved that problem, how did we do it, and what impact, precedent does that have for the problem we now have?
Well, we're still trying to solve that problem. The crisis system is a key to that, a key strategy, and that overall strategy to solve that problem. Improving access to care in the community, to get people early, catch people early, and make sure that they have treatment before it gets to the crisis level, so that we're keeping them out of the hospitals, and then making sure that when they do have, when they do are forced to go to the hospital, there's resources in the community after they discharge to keep them from going back. And so it's really kind of a holistic approach. The crisis response system is one major key to addressing that, but we're still building it out.
Okay.
Any other questions? Seeing none, thank you so much. Thank you, Delegate, for your leadership. Let us know when the bill is ready. Let the subcommittee. Thanks, Dan. No, we have next Tanya Schwartz and Leslie Frey. These are the last 2 witnesses for this evening. Afterwards, we do have weekly review for those of you that are in weekly review, because we love you so much. We don't want to let you go. Michelle said to tell you that. Go ahead. I'm blaming you, Michelle. Oh, you're there. Go ahead. Go ahead.
Good evening.
Sorry, we're just silly because it's late. Go ahead.
It is late. Thank you for staying. Thank you, Madam Chair, Madam Vice Chair, and committee members. My name is Tanya Schwartz, and I serve as the Director of Urgent and Acute Care for the Maryland Department of Health Behavioral Health Administration, which oversees 988 and crisis services. The Maryland Department of Health thanks the committee for the opportunity to provide support with amendments for HB 1146. This bill aligns with the department's efforts to build a continuum of behavioral health crisis services across the state. We want to ensure all Marylanders have someone to call, someone to respond to help them in that moment, and a safe place to stabilize and get connected to ongoing support. The department is proposing one addition to the bill and several changes to the original statute, as the bill sponsor alluded to ensure 988 services, to enhance 988 services and reflect current and planned data collection efforts. The department proposes adding that Maryland 988 centers must directly dispatch or provide warm handoffs to mobile crisis response and stabilization services and other immediate services as needed. This is a critical element of 988 for approximately 4% of people who need immediate in-person support after contacting 988. With respect to data, the department has been sharing 988 data monthly and working with jurisdictions and providers to improve crisis system data collection. Beginning in state fiscal year 2026, this enhanced data collection will capture the elements outlined in the bill. The department proposes refining the statutory data collection provisions related to law enforcement engagement, involuntary status, and diversion from higher levels of care, including hospitals, to more accurately and adequately capture the data that the department is able to collect. We also propose clarifying the vehicle for consumer experience reporting to be completed at the local level. Thank you for the opportunity to provide support for this bill. We look forward to continuing to work with you to ensure that behavioral health crisis services are available to Marylanders when and where they need them most. Thank you.
And thank you for being here, and thank you for working with a sponsor. I'm going to open it up for questions now. Are there any questions for the Department of Health? Delegate Taveras.
I know that you said that it was really seamless, but what happens with hotlines like the suicide hotline and the Trevor for LGBTQ?
Yeah, so when you call 988, you can get connected to specific subnetworks. So if you press 1, you get connected to the veteran subnetwork. If you press 2, it's for individuals who speak Spanish, and 3 is for the LGBTQ network. And so when you call 988 or contact 988, calls can be triaged to those appropriate places.
But what if you dialed the other number? Those are already disabled?
She's asking, are those obsolete?
I'm not sure which ones you're referring to. When you said the suicide lifeline, that is 988.
The ones that existed before we did 988.
Like Trevor?
Gotcha. So it's my understanding that some of the call centers have been consolidated, again, to really try to have one single crisis entry point, which is what this bill talks about. And so we are also working, there are some local hotlines around the state, and so we're working closely with the local hotlines and 988 to ensure that people get connected to the services they need.
Okay, thank you.
Delegate Hill.
So if I call the number that I would have called 5 years ago, will I get connected? Or have those numbers been disabled or are now obsolete, or will they tell me to hang up and call 988?
So I will get back to you on the details, but I do know that some of the call centers that existed have auto forwarding to 988.
So the numbers are still good?
So I want to get back to you on the specifics because I know there were multiple, but I'm happy to do that.
All right, thank you.
So the Trevor number is still working according to Dr. Google. It still works. But I know that you're trying, 988 is trying to integrate everything under one as well. So if you could, whatever information you obtain, can you send it to the whole committee, please?
Absolutely.
As well. Any other questions? Delegate Woods.
Thank you, Madam Chair. I was particularly interested in like the SAMHSA, that's Disaster Distress Hotline, and the Crisis Text Hotline.
I can take that for the record and get back to you.
Thank you. Thank you, Madam Chair.
Any other questions? All right, seeing none, I have only one person left. Leslie Bray, she's not here. Let the record reflect that we did call her. So this concludes the bill hearing on House Bill 1146. Please stay in your seats for a second, and have a good night, everyone. Thank you for your patience. Will you take us down? Let us know when we're done. I just have two quick